बिल्कुल। चलो बहुत बढ़िया। और क्या हाल है सिंधु?
All fine.
ओके, थैंक यू। चलो बहुत अच्छा लगा देखिए।
पार्वती मेरे फोन ले लो ना. Abhishek, can we start?
Just 1 minute, ma'am. I am sharing the screen.
Okay, I will tell you.
Yeah.
So you are in Mumbai? Sir?
We are live now.
Yes. A warm hello to everyone. Good evening, everyone. We welcome you all from the Public Awareness Committee. This is the 7th episode of our zonal webinars. Today's webinar is with the East Zone, and our topic for discussion today is cervical cancer, its screening, prevention, and management modalities. We would like to first take the blessings of the Almighty. So we'll start with the lamp lighting. Abhishek, please.
असतो मा सद्गमय तमसो मा ज्योतिर्गमय मृत्युर्मामृतं गमय ॐ शान्ति शान्ति शान्ति.
Yes, thank you, Abhishek. I would now welcome our chairperson, Dr. Priyankur. Yes, Abhishek, is it done?
Yes, ma'am. Just
Yes, thank you. Thank you. I would now welcome Dr. Priyankur, the chairperson of the Public Awareness Committee, and request him to kindly welcome our chief guest, Dr. Rishikesh Pai.
Thank you, Shatabdi.
And take it.
Yeah, first of all, good evening, everyone. Gives me immense pleasure to welcome all of you to this 7th episode of the Public Awareness Committee Core Connect program. And we are here with the East Zone societies today. And we are doing this program on the very important topic of CS cervix, which is one of the topics of prime importance that Dr. Rishikesh Pai sir has given us for this year. So Dr. Rishikesh Pai sir, of course, is the chief guest of the program, and we are really blessed to have him with us today. He's currently and has always been the medical director of Bloom IVF Group. He's currently the president of Fogsi. He is the administrator of the Fogsi Manyata Initiative, director of corporate affairs of IFFS, and he's a postgraduate teacher in OBGYN at DNB examination. And his main interest is, of course, IVF, ICSI, egg freezing, as well as genetics. He has received a number of awards to his credit, and he has been awarded the fellowship ad endum of the RCOG. He has been the past president of ISAR, IAG, MOGS, and MSR. And overall, to say, just to brief him in one word, he's an excellent person. He gives opportunities to juniors like always, and he is a person because of whom we chairpersons have been doing wonderful work in this year. So it's a pleasure to have you with us today. So requesting you to say a few words of blessings today for everyone present over here.
Thank you, Priyankur. You're our dynamic Public Awareness Committee chair. He has done a lot of work. You know, what people take 2-3 years to do, she has finished in 4-5 months. So it's a very dynamic and a good role model for a lot of younger people to emulate in the future. And I can see that this is the East Zone Public Awareness Committee, and there are a lot of stalwarts who are here today. Dr. Danwal is here from Bhagalpur. And then we have got Dr. Indrani Roy, with whom I've had a lot of interaction. She had done, I think, the program when Dr. Nandita was the president, and very efficient in doing the program. And then we have Dr. Kavita. We are looking forward to you and Dr. Jad for doing a very good critical care meeting now for the Fogsi. And we have got
Thank you.
Other Bhagyalakshmi is there. From very active cancer cervix person, and very active in the area of cancer for women. And then we have other things, Dr. Monica Oberman, who is becoming more and more dynamic, maybe future Public Awareness Committee chairman. We don't know what will happen. And then Dr. Suzy and a lot of other people are there. Satabdi is also very, I think, Priyankur, you have identified very good people to work for you, and they will be your future leaders. So
Thank you so
basically,
much, sir.
last 4-5 days I've been so, I was in Delhi 3 days. So once we went 4-5 days back for the hysterectomy. So hysterectomy is coming in a big way, but in the discussion which we had there, we also the government doesn't want surgeons to do the hysterectomy. So that's one good point that has come out of the discussion. Dr. Rekha Jha is also joined us. Welcome, madam. And so the government, so a hysterectomy less than 42 people's opinion will be necessary. There's a form. In fact, I have been trying to push the government to create a master form, not too much, just 2 pages, which all of us should fill for everything. So the data, because data is very important tomorrow, even from our medical legal litigation point of view. Tomorrow, if there's a patient who litigates us and we don't know what we did for that patient, so data is a must. So once some kind of mild coercion is there, you must fill the data. So I have told them that we should create a simple data form, patient name, mobile number, just a little address, then whether she wants for pregnancy or non-pregnancy, if it is pregnancy, whether it is for abortion or for continuing pregnancy, and outcome, and non-pregnancy, just, so all the classification and submit. And if they have a proper data bank, it will be fantastic. I feel that we all should go for it in a big way. So that's one thing. So hysterectomy is going to be a important. We'll now make the team, they will make a group on hysterectomy. And the second thing I've told the government is that you allow the associations to implement your policy. Suppose you have got Ayushman Bharat. If we tell Bhagalpur Society to implement it, they will do it very properly, and none of the members will do anything wrong. Because, when you do something wrong and other people are with you, you don't normally you do everything right only. Because it's not just making money out of it, but your reputation is at stake. So I feel that one, data keeping is very important. Second, association should be used by governments to implement their policy in the future. I also attended the abortion meeting, which was we attended for national abortion. So in that meeting, what I realized is there are certain important, like some form filling is very important. I told Richa Sharma, our chairman, please make a 1-page summary and give it to everyone, because if you disclose the identity in the new law, forget that 20 weeks. How many of us does 20 week plus? So if there is a 20 week, we'll send them to the professors. We don't want to touch them. But I'm talking about the less than 20 week one. So 12-week abortions and all, which we are doing. There is a clause that if you disclose the identity, there may be 1 year, 6 months to 1 year imprisonment. That is more important for all of us. So we have to, because now in the register, you will have to have a number, and that number should be used for giving any certificate. Or if you are going to have a discharge summary, you should not write the name of the patient in the discharge summary. So that I also didn't know properly. So, and there are certain forms. So there are 8 forms need to be filled. So this is very important information that we need to give the public. Priyankur, please note that we'll have to sit down, create the committee. So all this information is disseminated to others. We don't want any one of our members to land in jail unnecessarily, because from silly reason, by mistake, in the discharge summary, we wrote the name of the patient. Not prescription you write, you don't, and you write the name by mistake. So you can write the name, but you should not display the procedure for which you wrote. Or if you write the procedure, you must use a code. So that is the other thing I learned from the government. And the third thing, which I attended yesterday, I'm really tired. So I'm telling you, becoming Fogsi president is not a joke. It's really a lot of hard work. So yesterday was a maternal committee meeting of the government. All the top medical officers of the states were there. And the big issue was from them, they demanded from me. I said, Baba, I'll do the midwife for you, no problem. I'll do the decrease in the cesarean rate. I said, we'll increase the vaginal birth, we'll have an audit, no problem. They were asking me that you must help us with the PMSMA, which was launched. So when I was the Secretary General of Fogsi in 2016, we launched the PMSMA. Pradhan Mantri Modi ji was there. And along with that, there was Dr. IMA with us. Dr. KK Agarwal was the IMA president, and Dr. Alka Kriplani was the Fogsi president, and I was the Secretary General. So we launched it. Even today on the website of the PMSMA, our photos are still there. They have not even changed the website. So they were telling that time I had sent a SMS to all the people, and 1,500 volunteers had come from all over India. Now they said, Dr. Pai, we want the PMSMA to be done under any condition. So I said, Baba, kar denge hum log. So now what I want from the East Zone, what I want from you guys, from the PMSMA, we form a committee in the East Zone. We'll aggressively do it. So the Dr. Padmini Kashyap, who is the new commissioner of maternal health, she said that, doctor, 2 types I need from you. One is that we need our volunteers to go to the deep. So what I suggest is this corona remedies is here now Priyankur will catch them only. So what we'll do, we need to create a junior cadre. So suppose there's a district 2 hours away, they want a gynecologist for 2 hours on that day. I said, you at least give us a transport, or let us do the transport from our side only and identify our youngsters, and we can even give them an honorarium from our side. Forget the government. See, we have to see that there are 12 days, 9th of every month. Now, we have to see that we do it. I'm telling you, because if we do that covering of the 9th of every month for 12 days in the year, I'll spend pocket money from my pocket. I'll donate it. We all are well off. Let us donate money. Let us hire the ambassador cars or Innovas. Let us identify our juniors. If we can't go, we'll send our MD juniors. We'll pay them an honorarium of 1,000 rupees or something every day. And let us staff all their centers on that one day in the month. From our side, it's a gift to everyone. From Fogsi will give them that gift. The second thing she said, Dr. Pai, you can even do it in your clinics, not a problem. So we will mount a presidential initiative campaign all over India, where we will say on 9th of every month, just now we have the Badlao clinic, same clinic will use, 9th of every month, you come walk into a center and we'll give you free antenatal care. So let us now take all our societies together, and these 3 initiatives, especially the hysterectomy and the abortion, but the PMSMA is the most important. Dr. Kashyap said that in the secretarial meeting of the government, Mr. Modi was there and all the chief secretaries of the state were there. They want the PMSMA to be implemented. So what I realized that we must do the PMSA aggressively. All the other things that we do, they don't care. PMSMA is their favorite. You give them the PMSMA and then in return they will get. So the next to me in the last thing, I'm signing out, but the person from Madhya Pradesh, the chief medical officer of Madhya Pradesh was sitting next to me. She said, Dr. Pai, will you help me? You know, blah, blah, blah. I said, please take the number. I immediately made phone to Asha Bakshi. I said, Asha, Vice President of the West Zone, see what she wants. Do it. So we need to help the government. They need to feel कि अरे हमारे लोग हैं. I said, देखो हम हमारे आपके ही लोग हैं. And I told all the audience, I said, who are we? I was a registrar, then I was a lecturer, then I was a reader. I was honorary in the Kurla Baba Municipal General Hospital for 17 years. I did free work. I said, who am I? I am government. After I did all this, I went into private practice. So all of us, gynecs, are government people. Some of us now, we have to move on in life and we have entered private practice. That doesn't mean that we are not government people. We are all government. So that is what we need to do. We need to build confidence. It's very exciting. I tell you, I wish I could go back to and become Priyankur again, because I want to relive my life, but my life is nearly over now. This is the last 9 months of my life. And I would, of course, help all of you. Whoever wants any help in the future, my doors are always open to all of you. Whatever way I can help you, I'll always help you. But all of you now help the country. That is very important. We have got everything from our country. We have got money, name, fame, education, good children. So we need to pay back to our country. Thank you, Priyankur, for this. And of course, cancer service is a very important part of the government, but we need to integrate everything into one. Data entry is very important. One last thing before I leave, I want data entry to be started by all of us. Let us do it voluntarily. Even if 20% of us do it, the remaining of our colleagues will join us in the data. Data is very important for a country. With the data, we can plan our future action. Now, without data, how can we know what is the impact of what we are doing in public community health? So data is very important, and we have to make that sacrifice. We will have to spend 2 minutes of our precious time to enter that data for every patient. And they were saying, Oh, Dr. Pai, what about cash? I said, हम लोग cash ज़्यादा करते नहीं है. There is no money only. In our this thing, we will enter the data. You don't worry. Most of our charging is all done in check nowadays. We don't do crash transaction. So it's very important that we do all that. Thank you very much and wish you the very best.
Thank you so
Thank you
much.
so much. Yeah, thank you so much, sir, for your wonderful words. You said that you want to relive as we are living, but I would just say you that the king size life that you live, we all really are looking forward to such a life in the future as well for us. So thank you
It's
so much, sir.
emperor
Thank you
size,
for
it's
all the
not king
aspirations. And
size. It's emperor size.
anyways, thank you so much,
Thank
sir.
you.
sir.
I have to
Thank
go now. Thank you.
Yes, sir.
Thank
Thank you so much. So yeah,
And
we wanted to
before I go, our Bhagalpur meeting on critical care has to be a very
Yes, sir.
successful meeting. It is a
Yes, sir.
meeting, and it has to be all of you. I expect all of you to be there. I am going to be there.
Yes, sir.
So you all be there for that meeting. Thank you.
Sir, yesterday I got a call from somewhere, I don't know, but I have done under PMSMA before Corona time. So yesterday I got a call, ki, ma'am, please continue. We are giving you amount of 2,000 for that. I'm like, okay, it doesn't matter. I will continue. So yesterday
Congrats.
I was volunteering for last 5-6 years since it has been started.
Madam, I've also told Padmini Kashyap कि देखो हमारे लोगों को पैसा नहीं मांगते हैं पर हमको मान दो, हमको रिस्पेक्ट दो, हमको रिकॉग्निशन दो कि हम क्या करें. हम सब पैसे के लिए नहीं करते, सब मान के लिए करते हैं. We do it for the respect. If you give us respect, we will do not one day, we will do 10 days for you. We are bad doctors. We thrive on respect, not on money.
absolutely, sir. Thank you so much, sir, for these words. It means a lot to all of us, sir. Thank you so much.
Thank you.
So, yeah, we wanted to take your comments before I welcome all the others to this program. So, I would like to welcome Dr. Madhuri Patel, ma'am, who's the Secretary General, Dr. Alka Pandey, ma'am, who's the Vice President in charge for our committee, and of course, Dr. Kalyan Barmade, who's the immediate past chairperson, as well as
Guru,
our coordinators, Dr. Monica Umbardhan and Dr. Shatabdi has worked very hard at the for this zone. We have Dr. Rekha Jberg. She has joined this program and it's an honor to have ma'am worked behind this committee, and she has done a lot of work towards the success of this committee, lot of activities that she has already done, and Indranil is a co-convener with her. Our chief guest, of course, we have heard him, Dr. Rishikesh Pai sir. Our guest of honors today, we have Dr. PC Mahapatra sir and Dr. Shamal Sheth sir. Welcome to this program, sir. We have two talks, one on cervical cancer screening guidelines and the other on surgical management of cervical cancer, and they'll be delivered by Dr. Bhagya Lakshmi Nayak ma'am and Dr. Manisha Varnikar ma'am. So welcome. Our chairpersons for the sessions, Dr. Indrani Roy ma'am and Dr. Pranay Nath sir. Welcome to the program, sir. The panel discussion today is on screening methods and vaccination, a very important topic. Moderators for this are Dr. Asha Jain ma'am and Dr. Rekha Jha ma'am. Welcome to the program, ma'am. Experts for this session are Dr. Himali Sinha ma'am and Dr. Ashok Padi sir. Welcome. Panelists we have with us today, Dr. Sindhu Bala, Dr. Mukti Agarwal, Dr. Jitendra Panda, Dr. Kavita Banwal, Dr. Anju Singh, Dr. Indira Palo, Dr. Sushila Salam, and Dr. Sangeeta Thakur. I welcome all of you to this session and look forward to a really live session with a lot of discussion. We have almost 2,500 delegates who join with us in this Core Connect program. I'm sure the number is going to increase further, and I wish all of you a very happy learning session over the next couple of hours. I hand over this session to Shatabdi or Monica to kindly take over for the further proceedings.
Thank you, Priyankur. Thank you, Pai sir. It is always so good to hear from you. Abhishek, please proceed. I would now like to welcome our guest of honors for today, Dr. PC Mahapatra sir and Dr. Shamal Seth sir.
Shatabdi, I guess PC sir hasn't joined yet, and Shamal sir is there in another webinar. So maybe if she is not free, we'll take their comments a little later. So we can move on with the first talk and come back to the blessings from guest of honors later on.
Yes, absolutely. Okay, so we will wait for the blessings from Dr. Mahapatra sir and Dr. Shamal sir. We'll move on to our scientific session. Our first topic for today is a talk by our Dr. Bhagya Lakshmi Nayak ma'am on cervical cancer screening guidelines, and the chairperson for the session is Dr. Indrani Roy ma'am. Yes, Monica, are you there? Okay. Dr. Indrani Roy ma'am is a senior consultant and HOD at Nazareth Hospital, Shillong. She has been the president of Shillong Obsgynae Society between 2017 and 2019. And she also has been the organizing chairperson for the East Zone Yuva Fogsi 2019. She is a member of the Breast Committee of Fogsi. She is a current member of the Breast Committee and also a DNB teacher. We welcome you, ma'am, and we would be happy if you could introduce Dr. Bhagyalakshmi, ma'am, and if you could introduce the talk.
Thank you so much. And at the outset, I would like to thank the whole Public Awareness Committee, Dr. Priyanko, Dr. Monica, all for giving this opportunity. And I think it's a great webinar. It will be a very learning experience for all of us. So I take this opportunity to introduce Professor Bhagyalakshmi Nayak. Well, I think she's a lady who needs no introduction. She's been working with the cancer cervix for the last couple of years, and I have been also actively involved with her. She's currently the head of the Department of Gynecological Oncology at Cuttack, and she's also the chairperson of the Oncology Committee, which was between Fogsi 2018 to 2021. And she's the governing counseling member of ICOG. She's the honorary secretary of AGOI, and she has innumerable journals. She has a peer reviewer, and she has also received many awards. So, ma'am, we welcome you today, and we'll be looking forward to hearing a lot from you. And today, ma'am will speak on cervical cancer screening methods. And I think it is your subject. So the stage is all yours, ma'am.
Yeah. So thank you so much, Indrani. I think it was a pleasure to be introduced by you. I think Indrani is no less a huge worker in cervical cancer, and I think anything you give her, she really is able to produce. So at the outset, I really thank Priyankur and his team for actually choosing me for this talk. And of course, I also my respect to Dr. Pranay Nath. And I think, and all the seniors, and Paisar has given us a very nice outlook about what we can really do. So I think we are really underestimating our potentials. We have huge potentials, and we can really produce. And as our Modi, PM Modi has told that I think duty is a revolution. So once we start doing our duty, I think India will be somewhere and above US and all those countries. We look up to all those countries in awe, but I think we have to see how more we can produce. So thank you so much, all of you. So I'll take a minute to share my screen. Yeah. So hope my screen is visible, Indrani.
Yes, ma'am. Yes, ma'am.
Yes.
Okay. So I think we are all aware that WHO has given a call for cervical cancer elimination. And in May 2018, Dr. Tedros Adhanom Ghebreyesus, the Director General of the World Health Organization, issued a call to action for the elimination of cervical cancer. And thank God, they have realized that this is a totally preventable cancer. As in contrast to breast cancer, where actually prevention is not possible, we aim at early diagnosis. But cervical cancer is preventable, as we all know. And WHO Global Strategy to Accelerate the Elimination of Cervical Cancer as a Public Health Problem was presented and unanimously endorsed by the 73rd World Health Assembly in August 2020. And I think our own Dr. C.N. Purandare sir, Dr. Nirja Bhatla were all also involved in this elimination strategy that was launched by the WHO. And subsequently, the WHO officially launched the global strategy to accelerate the elimination of cervical cancer on 17 November 2020. So every year on 17 November, we commemorate this day as a it's a yearly celebration for us that we had launched it. So every year we try to scale up the activities that we had done last year, and we try to find out what more can be done. So every year 17 November is commemorated as a cervical cancer elimination day. So the targets of the global strategy are that by 2030 we should be able to vaccinate 90% of eligible girls against HPV, to screen 70% eligible women at least twice in their lifetimes, and to effectively treat 90% of those with a positive screening test or a cervical lesion, including palliative care when needed. So these are the targets we should be able to achieve by 2030, which is just around the corner.
So this is cervical cancer elimination initiative by WHO. So WHO guidelines for screening and treatment of cervical precancer lesions of the cervical cancer prevention. This is the second edition which has come up after the elimination drive has been laid down by WHO. So this is again reiterating the same thing, that 90% should be vaccinated, 70% women should be screened, and 90% again should be treated. So, and what does it aim, everything aim at? It aims at elimination, which means to reduce the incidence of cervical cancer to less than 4 per 100,000 women. So this is unlike polio, in which it is called eradication, where we really do not need to put up any more public health activity to prevent this disease. But cervical cancer is something different, because you know it's caused by HPV, which is ubiquitously present, and they are going to happen. So we have to put up a little activity, but it is not going to be a huge public health problem as it is today. So we have to meet the 1790 target by 2030, and so we have moved from the previous guidelines which WHO had to the newer guidelines. So let's look at what are the methods. So one method is the screen and treat, the other would be a screen, triage and treat. So basically the guidelines are little different for the general population as compared to HIV. So for the general population, it is basically a screen and treat or screen, triage and treat. So two things, we have two options for women in the general population. So, but WHO tells that it should be a high precision screening method. So WHO favors HPV DNA as a primary screening test starting at the age of 30 years at every 5 to 10 years screening interval. So, and for women living with HIV, it is always a screen, triage and treat. It's not screen and treat directly. So here in HIV, it is screen, triage and treat. And it is basically, WHO recommends HPV DNA as a primary screening test. But in HIV women, it should start at 25 years, because we know that the HIV women living with HIV are 6 times more prone to have cervical cancer as compared to women in general population. And here screening has to be done more frequently as compared to general women. This has to be done every 3 to 5 years as compared to 5 to 10 years in the general population. So screening and treatment approaches. In the screen and treat approach, the primary decision to treat is based on a positive primary screening test only. So once we have a screening test positive, we can go ahead and treat. So that's the basis of a screen and treat approach. Do a VIA, treat. Do a cytology report, treat. Do a HPV report. If she's HPV positive, you treat. So that is one method. The other method is screen, triage and treat approach. The decision to treat is based on a positive primary screening test followed by another positive second test with or without histologically confirmed diagnosis. So here we may not depend solely on histology. Suppose we get a HPV positive report. So HPV positive report means it's a HPV infection. We are not sure whether there is a lesion or not. So we do a cytology to confirm whether there is a lesion. We do a VIA to see whether there is a lesion. And then according to the report, based on the VIA or on the cytology, we treat. So it's called a screen, triage and treat approach. So two things can be done. So this is again reiterating the same thing. The recommendations for the general population, WHO recommends using HPV DNA detection as the primary screening test rather than VIA or cytology. So friends, as we know that we are heading towards a high precision test, which is HPV. So WHO recommends HPV ahead of VIA or cytology. But let me remind you that in areas where HPV testing is not available, we have to do something. So we are not going to give away VIA or cytology, because our government of India guidelines is still VIA up to 65 years of age in every 5 years. So we have to follow the method whatever is available with us. And so the existing programs with quality assured cytology as the primary screening test should be continued until HPV DNA testing is operational. So till it is available, I think we should have to continue with whatever methods we have. Similarly, with the HIV women, the WHO recommends using HPV DNA detection as the primary screening test rather than VIA or cytology. And so the existing programs with quality assured cytology as a primary test should be continued until HPV testing is operational. But again, with general women, it is with triage or without triage, but with HIV women, it's always with triage. So that is the whole essence, is that we move towards a high performance test and the role of a triage test. So we are moving from cytology and VIA to HPV based DNA testing. So it could be again screen and treat approach or a screen triage and treat approach. So this is why, because the prevalence of histologically confirmed cervical precancer and cancer among 1951 women living with HIV. Here we can see that the HIV in HIV women, even between 20 to 24 years, between 25 to 29 years, the blue portion shows that this is CIN 2 and 3. And I think we all understand that CIN 2 and 3 are the high grade lesions. And so these lesions are already seen by 29 years of age in the HIV positive women. So HIV positive women need to be screened earlier as compared to normal women, in which cervical CIN 2, 3 lesions appear a little later. And if we do the HPV test earlier than that, we would get a lot of false positives and end up treating lots of women who would really not need them. So women with HIV need to be retested more frequently after a positive screening test and after treatment before moving to routine screening intervals. So it's 12 months for women living with HIV and 24 or 12 months for women in the general population, depending on the test and the context in which you are working. Once a decision to treat a woman is made, it is good practice to treat as soon as possible within 6 months to reduce the risk of loss to follow. But it's the best thing to treat whenever she has come to you for the screening. Women who are pregnant, you can defer the treatment until pregnancy is completed. In circumstances when treatment is not provided within this time frame, we can re-evaluate the woman before treatment. And at the same time, recommendation on HPV self-sampling. When providing HPV DNA testing, WHO also suggests using either provider or self-collected samples. I think self-collected samples will give you an ample solution to all those problems that women really don't like to come to the health center to get themselves checked. So we can reach the last mile if we go ahead with the self collection of HPV, and I think that's the way forward. So, and then the age to stop screening. So if you once you start screening, when you should know when to stop screening for the general population of women, and it's different for the women living with HIV. For the general population of women, priority age is 30 to 49 years, and for women living with HIV, it is 25 to 49 years. So 50 to 65 years for women who have never been screened. So in these cases, you can only above 50 years, you should screen women who have never been screened. So ideally, WHO advises us that we stop screening at 50 years, only then in women who have already been screened, not in women who have never been screened. So when tools are available to manage postmenopausal women, we should be able to screen them. So the summary of evidence shows that with the 3 types of tests, the HPV, VIA, and the cytology-based screening, you can see that the cervical cancer rates are reduced maximum 46% as compared in HPV as compared to VIA 39% and cytology 44%. And similarly, the mortality due to cervical cancer rates have been less when the HPV test is used as compared to VIA and cytology-based test. So HPV compared to VIA cytology in general population shows that HPV prevents more precancer and cancer and saves more lives than VIA or cytology. Similarly, fewer treatments and preterm deliveries with HPV or cytology than VIA, and higher cost with cytology. I think cytology costs pretty much than HPV testing. So general population HPV rather than VIA or cytology. Similarly, HPV alone versus HPV and triage in the general population both prevent cancer and save lives, but HPV along with triage would reduce the number of treatments, but I think it has not shown any much cost benefit. Similar number of treatments, preterm deliveries and costs. So general population HPV rather than VIA or cytology, HPV alone or with triage. I think, okay. So similarly, as HPV compared to VIA or cytology, also in women living with HIV, HPV prevents more precancer, cancer and saves more lives than VIA or cytology. And similarly, HPV and cytology reduce treatments more than VIA and greater cost with cytology. So again, HPV alone or HPV triage compared to cytology, HPV based testing prevents more cancer and saves more lives. So these are all the evidence which shows us why WHO is recommending HPV testing. And I think in India, we could think that because India is a very diverse country, that some people would think that HPV is not available in my center. What should I do? But please be optimistic. We are going to have many Indian platforms that are coming up with HPV testing with point of care results, so that you can have your results immediately and can use it for community-based screening also. And treatments are reduced by half with triage. Costs are similar with or without triage, and greater cost with cytology. So even if you use HPV with triage also, the cost is less than cytology-based screening. So general population HPV rather than VIA again, or cytology, and HPV alone or with triage. But women living with HIV, again, for all the studies have concluded that HPV with triage rather than HPV alone or VIA or cytology. So, and in general population, it has to be done every 5 to 10 years, and in women living with HIV, every 3 to 5 years. So the costs are, I think, to consider as a threshold price when discussing with test providers. So the choice of a screen and treat strategy versus triage and treat strategy. So impact of both strategy are similar. There is reduction of cervical cancer and reduction in deaths. Health system with triage, there is a reduction by the half of the number of pre-cancer treatment, and the cost of HPV alone and HPV triage are almost similar. And the choice depends on the context. So where you are working, so the capacity of the healthcare system to provide triage tests compared to more treatments when not using triage. So you have to discuss with your providers where in which context you are working, whether there is access to the services, whether there is HIV prevalence, whether the women would accept to come back again for a triage. So all these things have to be taken into account, whether you do a screen and treat or screen triage and treat. So we need, how do we achieve all this? So we need a national scale up of screen and treat. Simple algorithms need to be introduced and adapted to settings, increase quality and coverage of service delivery, countries' detailed implementation plans to introduce and scale up products and delivery models, and strengthen patient retention and linkage to treatment. That's very important. I'll come to that next. And sufficient affordable supply of screen and treat technologies and products. And of course, we have to monitor the progress. So these are all the workbooks that are available on the WHO website. So I think we can end cervical cancer. So the recommendations, we have already gone through that. So let's just focus a bit about the treatment part. So once the screening is not going to cure the patient, so it needs to back up by some kind of treatment. So we have many newer approaches also coming up. One is a molecular test, one is a cytology based, liquid based cytology, one dual staining. All those things are very advances that are coming up in cervical cancer screening, and it's a in thing now, and the whole world is looking at cervical cancer screening. So let's look at a few algorithms for screen and treat strategies, because if you only screen and don't know what to do with them, then again that's a difficult story. So if you do a VIA testing, if it is negative, you can safely call back after 3 years. Or if she is positive, she is eligible for ablation, you can do a thermal ablation, which is quite an easy method, takes around 20 to 30 seconds only. It's a handheld object with a charge used by user rechargeable battery. Or if she has a lesion in the cervix which is not eligible for ablation, you can do a large loop excision of the transformation zone and you send it for biopsy. If the biopsy is something less than that, we need some post-treatment follow-up after a year. Or if she has cancer, you send her to a center which is equipped to treat it. But in the VIA test, if you see or suspect cancer because you have a good look at the cervix, so you refer her to a higher center. Similarly, if you are you have access to HPV test, if she is negative, you can rescreen in 5 to 10 years. But if she is positive, again, you need to determine eligibility for ablative treatment, because HPV positive doesn't mean cancer or a lesion. So you have to do a acetic acid test to identify the transformation zone. If it is eligible for ablation, you can do ablation. Not eligible, you can do a large loop excision. If there is any suspicion of cancer, you have to refer. So I think it's very important to look at the cervix, even if we do self-sampling, but then if she is HPV positive, calling her to look at the cervix itself is very important. So if you have access to cytology, then again good. If it's negative, it is screened after 3 years. If she has a report called ASCRS, which is atypical squamous cells of undetermined significance, immediate triage with HPV test, because this is a high risk lesion. HPV negative, rescreen in 3 years. If she is HPV positive, then we do a colposcopy and then further management. But if the report shows more than ascus, that's a direct indication for a colposcopy and further assessment. So the other thing with the HPV DNA testing is that if she's negative, we have already discussed. If she's positive, you can also do a HPV genotyping to say 1618, because most of the cancers in the cervix are caused by 1618. So if 1618 is positive, so directly you can go ahead, eligible for ablation, you do the ablation. Not eligible for ablation, you can do a large loop excision. But if there are other high risk positives, you can do a VIA triage, follow the steps after VIA triage, and if there is suspected cancer, of course, you have to refer the case. So again, if you are doing HPV DNA testing, you can do a VIA triage and the same steps are followed likewise. But there is another option which WHO has recommended, that if it's HPV positive, you can also do a direct colposcopy and manage accordingly. And of course, you can also do a cytology triage if she has HPV positive, and if negative, repeat HPV testing. So I think when two things come together, you need to use your decision as to how to manage. But then WHO has given you this opportunity that if it is HPV positive and you're thinking that the woman may not come back again, then you can always ablate her transformation zone completely. So follow-up test at 12 months post-treatment for the general population of women. If treated with ablation or leaf excision, follow-up test at 12 months. If negative, we can back to routine screening interval. If positive, again retreat with leaf and post-treatment follow-up after 12 months. But if there is any suspicion of cancer, of course, you have to refer. But in HIV, the management is little different. You follow up test after 12 months. If it is negative, again follow for 12 months. If negative, then she goes back to a normal routine screening. But if she is positive, again retreat with LEAP and post-treatment follow-up test within 12 months. So if you are doing a HPV NAC or VIA, again you can do direct eligibility for ablative treatment, eligible for ablation, ablative treatment, ineligible for ablation, you can also do excise. So screening does not save lives, friends. We have to remember this line very thoroughly, that screening does not save lives, and treatment of screen detected lesions has to be done so that we get some output of the screening methods. So single visit approach is to be encouraged. Screen and treat approach with VIA, HPV, cytology, whatever is feasible should be done. And colposcopy for a screen, triage and treat approach is mandatory. And now we have so many colposcopes available with artificial intelligence that the learning curve of colposcopy itself has gone down. So we can learn colposcopy and do it very easily. We have portable colposcopes which can go to the last mile. Health workers can capture and transmit images, and incorporation of artificial intelligence will really tell you sitting in your chambers that what your health worker is doing. You can interpret the lesions in the cervix by looking at your screen. So these are very excellent pocket colposcope images that you can see and interpret. They are now very easily available. So I think continued screening is still needed. What should you do if the woman has already had a HPV vaccination, which is now being available more and more frequently? So continued screening is still needed. Current HPV vaccines do not protect against all HPV types that cause cervical cancer. So it is important for vaccinated women to continue to undergo routine cervical cancer screening. Please remember this. So when we are vaccinating, we have to tell them there's still a need for screening. And cervical cancer cytology screening recommendations remain unchanged for women who have been vaccinated for HPV, because 20% to 30% of cervical cancer is caused by HPV types not included in the vaccine, and sexually active women could have been infected prior to vaccination as well. So the screening guidelines call for women who have been treated for precancerous lesions or cancer to continue screening for at least 20 years, even if they are over 65. So if you have treated someone for a precancer, it's better to continue treatment for at least 20 years. So WHO 2021 in particular, it recommends an HPV DNA based test as the preferred method rather than visual inspection with acetic acid or cytology, commonly known as a pap smear. Currently, the most commonly used methods globally to detect cancer lesions. And HPV DNA testing detects the high-risk strains of HPV, which cause almost all cervical cancers. And whom not to screen? I think you should remember who do not need any screening. Women more than 65 years who have had adequate prior screening with normal results and who are not otherwise at high risk for CS cervix, and women who have had a total hysterectomy and have no history of high-grade cervical lesions or cervical cancer. So I think, friends, we have to remember that human suffering due to cervical cancer in India is depressing, because 1 out of 4 women who die due to cervical cancer in the world is an Indian. So I think it's a little shameful for all of us. And now you have to remember, understand, and that it is in our hands, as Dr. Pai has told, that it is in our hands that to bring back a little smile to these women. So I think it's our work that we have to do. But before I end my talk, I have to tell you that please remember that there is still a group of cervical cancer which are HPV independent. So if you are doing HPV test, it's negative, we are calling the patient back after 5 to 10 years. But then we have to counsel them that in between, if they have any symptoms, they have to come back, because there is still a group of cancers which are HPV, purely HPV negative. So thank you very much for your patient hearing. Would be happy to take any questions.
Thank you so much, ma'am, for an excellent presentation. I think you've covered the topic so well. I think it's a lot to learn. And I think the way forward is HPV testing. I think that's what the message goes, screen and treat. And of course, as you have said, that self-testing, I think that's going to go a long way in future. To look for the future is self-testing. Thank you so much, ma'am, for your wonderful delegation.
Thank you, Bhagyalakshmi ma'am, for your excellent talk, and thank you, Indrani ma'am, for chairing this session. We now move forward for the next session. This session will be chaired by none other than Dr. Pranay Nath sir. And our speaker for today is Surgical Management of Cervical Cancer by Dr. Manisha Vernecker ma'am. Dr. Pranay Nath sir is a professor and head of the Department of Obstetrics and Gynecological Department at Silchar Medical College. He is also the organizing secretary at NEOSCO in 2005, and he has been the former president of Silchar Society. We welcome you, sir. So can you please carry forward the session?
Thank you very much, Dr. Monica. It is an honor to be there on this platform where I can see all the stalwart of the country, like Professor Pai was talking. And definitely before we go to the next talk, I like to thank the previous speaker. It's an excellent presentation on the prevention of cervical cancer. However, until that period of time where we can prevent it to the best of our ability, there will be always a place of doing surgery. And today, regarding surgical need and the surgical procedure, we are having a very learned the surgeon along with us in the cancer surgeon. What I can see about her, she is working in Chittaranjan Cancer Institute, and her key interest in various aspects of the medical and surgical oncology. Especially, she is more interested in ovarian cancer. And she is also interested in laparoscopic procedure. She updates on gynecological oncology treatment, procedure, and development. Her key interest in preventive oncology and cytoreductive gynec oncology. She is member of the many department, the different societies and committees, indicating itself that she is having keen interest in the field of oncology. So, Madam Manisha, it is my honor to welcome you with your deliberation. So, thanks everybody. And Dr.
Thank you. Thank you so much, sir.
Yeah, please.
Thank you so much, sir, for the kind introduction. And on behalf of this, with this context, I would like to convey my thank you, and for this giving me the opportunity with the Public Awareness Committee Fogsi, especially Dr. Priyankar Roy and his team. And it is my privilege and of course the honor to be on this platform to present a talk on the cervical cancer, the surgical management, which is a very important aspect. Now, what we have just recently seen, what Bhagya ma'am has talked on, a very nice lecture on the cervical cancer guidelines, screening and all. And what basically I'll be speaking on the tertiary management, that is a surgery. So I'll just share my, right. So can I, my slides are visible?
Yes, ma'am, your slides are visible.
Yeah. Thank you so much. So it was such a wonderful talk given by Bhagya ma'am. She had covered all the aspect of cervical cancer screening, guideline, and of course, the primary prevention and also the management of the pre-invasive lesion. So as we know, what even Bhagya ma'am has said, like every 1 out of 4 women we lose in the world, the Indian woman of cervical cancer. So with this, we know cervical cancer itself is a burden worldwide and also in our country. So we lose one woman every 8 minutes, and it is the important and the leading cause of death among our women. And mostly, sorry, and mostly we loses the woman in the mid, when the woman is required in the, especially in the mid age, when the family requires the woman to run the family, to run the make the children grow. So that is a period, that is 40 to 50, we lose them. So this is our responsibility, the gynae oncologists of the country, to make them cure not only from the cancer but also right from the primary prevention, the vaccination, then the screening, and of course once they develop cancer, the right proper timely management of the cancer. So we have seen, as per the Globocon recent data, the India contribute to the maximum number of cervical cancer, the mortality and also the morbidity and also the incidence of the new cases worldwide. So there are different aspects of this cervical cancer. The primary prevention, what Bhagya ma'am has already covered up in a very very nice way. So first of all, we know regarding the HPV vaccination. And recently, India also has developed its own Make in India vaccine, and it will be, of course, already many people are using it. And our institute was one of the site for the trial for this Serum Institute for a trial, and I was one of the co-PI. So it was a privilege, of course. So now we are already we are also doing the HPV vaccination among the girls and the boys of West Bengal, different community and different district of West Bengal, and it is free of cost. And then we are also involved in cervical screening, that is secondary prevention, especially 30 to 60 years of age group. And we are involved in screening right from the outreach camps, going to the outreach outskirt of West Bengal, the Sundarban, and where we cannot reach, we go over there. Especially also during COVID era, we have continued with the screening. And after that, whoever is positive, and we also do the screen triage and wait method. We do the see and treat, we do the screen and treat, all the aspect of screening. But yes, we make sure that the woman doesn't lose the opportunity of getting treated herself with the pre-invasive lesion if diagnosed. And yes, being a tertiary cancer institute, and I am in the institute wherein Dr. Subodh Mitra itself is a pioneer of this Chittaranjan Cancer Institute. So I'm honored to be in this institute working as a consultant. So we are involved in also the tertiary care, that is right from the pre-invasive treatment to the surgical management and also the adjuvant treatment related to cervical cancer. So in May 2018, what Bhagya ma'am has already said, that WHO took a call so that we make a 90% HPV vaccination with 70% cervical screening and almost 90% reduction in the mortality of cervical cancer. So the vision would be a world without the cervical cancer, and the goal will be 4 cases of cervical cancer per 100,000.
फाउंडेशन कोर्सेज 8 स्टैंडर्ड से है अपने पास, सोलापुर में 8 स्टैंडर्ड से दे रहे हैं.
Sorry. So coming with the latest, we had to FIGO 2018 cervical staging. There was a recent from 2009 staging. There was a change. So new incorporation of the staging was done with in stage 1B and stage 3C accordingly with radiological and pathological. So with this, it is divided as early, locally advanced, and of course the metastatic disease of cervical cancer. So now coming with the main aspect of the topic, that is a surgical management. So basically the therapy depends on the age of the patient and of course the general condition, the performance status at the time of presentation, and the accurate diagnosis right from the clinical staging, pathological, and the radiological diagnosis. And then the pathological, that is depth of invasion, presence of LVSI, and also, yes, of course, as I said, the woman present in mid 40s, somewhere in 30s. So sometime now we are seeing patient coming even in early 30s with an advanced case of cervical cancer. Because in India, we have early marriage, so they come with somewhere in 30s with the advanced case of cervical cancer. So if they willing for fertility desire, if they present in early cancer, we can go for fertility desirability of that. Accordingly, we can go for the treatment. And of course, the proper staging of the cervical cancer as per the FIGO stage and the presence of the lymph nodes. So the surgical, the surgical principle with this management of the micro-invasive cervical cancer, it depends upon the diagnosis. In case of tumor 1A cancer, it should be based on the conization or the excision. So mostly we prefer for conization specimen, which is examined by the expert patho-oncologist. And the LVSA presence carries a maximum prognostic significance, and when present, the lymph node dissection has to be performed because the chance of presence of lymph node, and that can cause a recurrence, and also the prognosis will vary. And nowadays we have validation of this sentinel lymph node biopsy in such cases, so we can decrease the morbidity of the surgical concern. So parametrectomy or the removal of the parametrium is over treatment sometimes in case of early cancer. So it is recommended only in case of larger multifocal tumor with LVSI positive. So the aim is to remove the positive parametrium node and not the parametrium in case of early cancer. So fertility sparing procedures are always the accepted management option. So we have to give the proper counseling, the proper management aspect, and of course the future prognosis and the outcome. When we go with the fertility sparing surgery, we have to explain the couple the aspect of it. Though the surgical approach, in case of low risk, as I've said, depending upon that, we can go with the conization or maybe simple hysterectomy, and of course the trachelectomy, and also including with the lymph node dissection or sometimes with the sentinel node dissection. So the prognosis significance of the lympho LVSS space. In case of stage 1A1 and A2, that is early cancer, there are some literature we have been given, and depending upon the LVSI, the higher the stage, the more positive node, lymph node, and that can vary with the prognosis of the cancer. So the LVSI is always associated with lymph node metastasis in patient with stage 1A cervical cancer, and also it is associated with decreased survival of women with stage 1A2 cervical cancer. So management of stage 1A1 disease. So in this case, the conservative management with conization for in case of the woman when want to preserve the fertility, and make sure the margin is always negative. So the primary treatment would be just the conservative management, that is conization. We can go for simple hysterectomy even she not desiring to keep her fertility. So in this case, when we do bone biopsy, the margins are negative, we can just observe. If the margins are negative sometimes and it is operable, we can go for simple, that is enough in when she doesn't want to keep her fertility. But if in case margins are positive, then we have to repeat the cone, or we have to go for modified radical hysterectomy with pelvic lymph node dissection, and preferably sometimes sentinel lymph node dissection if the facilities is available. And this is also recommended by the NCCN guideline. So in case of stage 1A1 with LVSI, so the woman who wants to preserve her fertility, as per the FIGO 2021 cancer report, the cervical conization with negative margin and close follow-up with pelvic lymph node desirable. And also the ESGO Astro ESP concession 2018 recommended the radical trachelectomy can be considered, or also conization or simple trachelectomy is also an option. So if the woman doesn't want to keep the fertility, then the guideline says the pelvic lymph node with extrafacial hysterectomy, which is, and also the lymph node staging is considered as per the ESGO consensus. And sentinel lymph node is validated, so that can be also another option. And conization can be still considered as a definitive treatment, as hysterectomy doesn't improve the outcome, because that can counteract the morbidity related to hysterectomy. So radical surgical approach, that is radical hysterectomy or removal of the parametrium, represent the overtreatment. So that is unnecessary for the early cervical cancer. So in case of stage 1A2, if the woman wants to keep the fertility, FIGO 2021 report says that cervical conization with pelvic lymph node, meaning does the conization and from above pelvic lymph node, it may be laparoscopic or may be open, and also radical trachelectomy with node dissection. And it is, ESCO report says the conization or just a simple trachelectomy is enough if for LVSI negative cases. And if LVSI is positive, then more radical trachelectomy has to be considered. And if the woman doesn't want to go for fertility sparing, then we can go for type B type of radical hysterectomy with pelvic lymph node dissection. So this is the flow chart which is showing in fertility preserving, and in case of the one who is not considering for fertility preservation, and it is also accepted by as per the NCCN guideline. So conization, basically it is the intent to remove the endocervical and the ectocervix en bloc using just a scalpel, a blade, and this provides the pathologist with an intact non-fragmented patient. So now why can we think like, why not excision, large loop excision? Because sometimes when we use the electrosurgical procedure, that is excision in case of loop or LETs, we use a cautery, so diathermy. So that causes the destruction of the margin, and that can give a false a negative. So in this case, we prefer conization. So this can gives pathologists a proper result regarding the margin, and we can give the further evaluation of the management. So the shape and the depth of the cone biopsy has to be tailored with the proper size, type, and also the location of the lesion. So this has to be make sure that whenever we do the conization, the cone has to be properly marked, labeled, and also the depth has to be measured. At least we have to preferably give at least 1 centimeter, and we can also increase up to 2 centimeter in patients who have completed childbearing. So the endocervical sampling sometimes recommended in case when we have to evaluate the residual disease, in case if it is recommended. The cone biopsy is indicated for triage and treatment of small cancer where there is no likelihood of cutting the gross neoplasm. So sometimes we think, what if conization margins are positive? Suppose if the conization, the cone margins comes positive, what we can do? So as per the NCCN guideline, they say perform a repeat cone biopsy, and also recommended by the FIGO 2021 cancer report. So in case of 1A LVSI negative cone, we does the cone. If the tumor-free border and negative, then it is endocervical curettage after cone, or if positive margin, then we have to go for reconization. So there are some literature also report regarding the cone biopsy and the simple hysterectomy. So we can see in case of stage 1A2, there are more 5-year survival rate is almost 96% in case of hysterectomy, and 90% in case of conization. And likewise, in case of adenocarcinoma pathology, it is almost 98 in case of hysterectomy and 97 in case of conization. So this is the data which is given in 2012. So also they said depending upon the type of radical, the type 1 and the type 3. So there is no any difference between the pattern of recurrence, although the 5-year survival in case of stage 1B to 2A type of cancer. So what are the indication of trachelectomy? Sometimes I have already discussed. So sometimes when we desire for preserving fertility, and if there is no any fertility problems earlier, in case of stage A1, 1A2 lesion, and also 1B1, that is less than 2 centimeter, with stromal invasion of less than 50%, that is more important. And also sometimes additional several variation, like sometimes you to go for anicety, sometimes there are so many trials which are going on, and except in neuroendocrine histology, because neuroendocrine histology is a very aggressive disease, and also it requires like chemotherapy has to be given, and more surgical aspect has to be taken. So what are the oncologic outcome of the trachelectomy? So in case of trachelectomy, there is no difference between the groups, whether it is recurrent rate or maybe overall survival related to trachelectomy. So in this case, there are around 10 to 13% of the patient found to be infertile. And in case of vaginal radical trachelectomy is more fertility saving than the radical abdominal radical trachelectomy, and the miscarriage rate is found to be in case of first trimester it is 20%, and as the trimester increases it is less, it is almost 3%, and almost 73% of the pregnancy has reached third trimester and almost 75% is delivered at term. So this is a report which is published 2012. So what are the principle of surgical management in case of macro-invasive cervical cancer? So basically here it is to come, the nowadays the 2018 FIGO staging, the main motive, the main the modality for the treatment is to decrease the double burden, that is the surgery and then followed by radiotherapy. So the decrease the morbidity to improve the quality of life of the patient. So that was the main motive with this. So with this aspect, it is like to avoid the combined modality of treatment, because we can see we operate the patient, sometimes they require the radiation. So the morbidity related to surgery and the radiation is very cumbersome and very difficult for the patient to tolerate. So that was the aim, and the aim is to also remove of the parametrium with some part of the vagina, that is radical hysterectomy. So it can be open matter, of course, with so many trials. Open method of surgery is a gold standard, and pelvic lymph node is always performed. And nowadays there's also a sentinel lymph node dissection being done, and there are so many trials being conducted. So the fertility sparing surgery can be still offered in selected cases with the proper counseling and the proper discussion. So there are many randomized studies with comparison of radiotherapy and radical surgery. So they have been seen the 5-year overall survival is almost 83% in, and the disease-free survival is almost 70% in both the groups. So only thing, the recurrence rate is almost similar, 25% in case of surgery and 26% in case of radiotherapy. So that is the thing. So if you go for the surgery followed by radio, it doesn't actually improve the outcome. The outcome is same. So it's better you give the single modality so that it gives the proper quality of life for the patient. And there are also treatment related which can avoid the combination of treatment, that is radical surgery and radiotherapy, because of its related high morbidity. So it is found that the morbidity and relapse rate is more in case of surgery followed by radiotherapy. There are some studies. So the long-term morbidity is found to be more in case of combined treatment. So if a combination of risk factor is known at the diagnosis, which will require an adjuvant treatment, so the definitive radiochemotherapy or brachytherapy can be considered without previous radical pelvic surgery. So we have to know the proper the staging, the proper pathological status, so that we can decide upon the proper management, so that we can decrease the burden, the morbidity to the patient. Now, in case of stage 1B1, so as per the FIGO 2021 report, the fertility sparing, we can go for radical trachelectomy. And when a vaginal approach is planned, the pelvic node are first removed. That is a Dargent approach. A laparoscopy or maybe open. Send for frozen. If it is negative, then proceed with the radical trachelectomy vaginally. And if the nodes may be first assessed by conventional pathological, sometimes the frozen is not available. So we can just assess by pathology. After 1 week or so, maybe you can go plan for radical trachelectomy as a second surgery. And in case when the patient not required for fertility sparing, then we can go directly with the modified radical hysterectomy with the pelvic lymph node dissection, of course. So there are many trials which are aiming for the change in practice. Is being conservative okay, or maybe radical is okay? Started in 2010 and completed in 2019. So it was a prospective trial which focused FIGO 2009 1A2 and 1B1 cervical cancer. And the selected patient with early stage low risk cervical cancer, that concluded may be offered with the conservative surgery, because it was found that median follow-up rate of the participant of 36.3 months, and that indicate that 14 pregnancies have been reported out of 40 women, and out of these 14 pregnancies, 13 delivered at term and one resulted in fetal demise, unfortunately. So there was another trial, that is SHAPE trial, and there were two arms, the control and the experimental, of course, and these results are still under um, uh, published. So in case of stage 1B2 and 2A1, what we can do? So as per the FIGO 2021 cancer report, the surgery or radiotherapy can be chosen as a primary treatment depending upon the other patient factor and the local resources availability, as both have similar outcome. So the advantage of the surgical treatment depending upon the feasibility of the post-operative stage precisely based on the histopathology. So the histopathology result or the status has to be properly labeled, properly the finding has to be given properly, so that we can depend upon that we can give the further adjuvant treatment, and this can also individualize the post-operative treatment. So that is possible to treat the cancer that are likely to be resistant to radiotherapy, and also sometimes we think about possible to conserve the ovarian function, because there are metastases to ovary as well. And in that context, the intraoperative transpositioning of the ovaries high in the paracollic gutters always from the radiation field, because after the surgery we sometimes they require radiotherapy, so that to avoid this post radiation ovarian failure, we have to think about this, so that we have to place the ovaries away from the radiation field. So this has to be subsequently checked. And the preservation of the ovarian, also the very important sexual function in case of sexually active women, that has to be preferably checked. And standard surgery is of course open type C. It may be the nerve sparing surgery, C1, radical hysterectomy with bilateral pelvic lymph node dissection. So this is a post chart as per the NCCN guideline. So what about in case of stage 1B3, that is less, more than equal to and more than 4 centimeter lesion, and 2A2. So as per the FIGO report, the larger tumors with high risk factor like positive node, positive parametrum, positive margin, which is necessitating, of course, adjuvant CTRT. And CCRT, that is concomitant chemotherapy radiation, is the preferred treatment. So in this patient, we have to go for directly radiotherapy without any hesitation. That's why the imaging is very important after the clinical staging, and as per that we can decide upon the adjuvant treatment. Now, just going with brief with the radical history. So as we know, history start in 1895 with the Clark and Fries type of, that was first radical hysterectomy which was conducted, followed by Werdheim, and then comes the Shota, Okabayashi mix, and of course the Kobayashi, that is the nerve sparing radical hysterectomy in 1961. And of course, Dr. Subodh Mitra, that is Mitra's operation, which is being conducted in our institute, and I'm really lucky to see and to do the surgery along with my seniors. So we are doing these operations here in institute, and then a recent modern history also, like the Argent type of, then Colomoro classification of this hysterectomy, and so on. So the radical hysterectomy is classified depending upon the class, that is Piver-Russley-Smith classification, types, that is Colomoro, and it is updated year-wise, that is 2008, 11, and now in 2017. So it can be the open vaginal laparoscopy, or maybe nowadays the recent, that is robotic. So as per the Piver-Russley-Smith classification, it is types. So it can be type 1 extrafacial hysterectomy, type 2 is resection, that is Werdheim hysterectomy, type 3 is classical radical hysterectomy, that is also to be called mix, and type 4 is resection of the periurethral tissue, vasa vesi superior, or porthipro of the vagina is more extensive, and type 4 is a partial resection of the, that is exenteration, what we call. So this is a table form which is divided, where to ligate, what to remove, and how to, what is the level. So accordingly it is divided, type 1, type 2, type 3, type 1, type 5. And then the Gynecologic Cancer Group, European Organization of the Research and Treatment of Cancer classification, and it is divided as 5 types. And of course, the collomotor classification recent, and it is divided as type A, type B, type C, and that is C1 is now sparing, especially in the young woman and we really have a good result with it, especially with the bladder function and the sexual function as well. And we can see there are certain flaws in different classification of the radical hysterectomy. So in case of Peever Russell Smith classification, class 1 is not actually radical, and class 5 is obsolete, and class 3 is 4 are not clearly defined in terms of anatomical leadfall. So that is the flaws and the is numbered by the letters, and the extent of the parameter resection is a key for this. And anatomical landmark has to be clearly identified and classified. So some brief on the nerve sparing radical hysterectomy, the type C1. So that refers to the surgical steps to identify the hypogastric nerve, that is a key anatomical organ which has to be identified and preserved. And because this is the inferior hypogastric nerve plexus and its bladder branches and the pelvic splanchnic nerve. So this is the allowing dissection of the oncologically related pericervical structure while preserving the sympathetic and parasympathetic innervation of the pelvic organ. So the aim is for the preservation of the autonomic nerve, so which is innervating the bladder in order to maintain the postoperative bladder function as well as the rectal and the vaginal function. So that gives a proper and a better quality of life in case as far as sexual, physical, and the bladder bowel is concerned. So what are the complications which can be seen following radical hysterectomy? So mostly we see blood loss, transfusion is if with the skill surgeon does, of course, the minimal blood loss, but we can see most of the blood loss around 23%. And of course, other than nerve sparing, we can see avoiding discuss function, especially immediate post-operative, around 40 to 42%. And others like sexual dysfunction, lymphedema. Yes, we can see lymphedema image post-operative. So that is a common complication which can be seen. Risk of fistula formation, fecal and fetal incontinence, and of course loss of fertility in some patients. So there are of course the level of node dissection. So as per this, it is divided as level 1, 2, 3, and 4 and 5. And in this context, the sentinel lymph node biopsy has been come, especially in the early cancer, where we can go for sentinel lymph node and the conservative surgical management in case of fertility sparing. So there are also certain trials that is called Senticol, and now we as institute also involved in Senticol 3 trial, and we have already enrolled 2 patients in this trial, the cervical cancer, and the trial is still going on. And also there is Centix trial in case of sentinel node biopsy. So I'll just go with the brief. This is the cervical NCCN guideline which quote regarding the sentinel node dissection and the indication and the importance. So in case of removal of the sentinel node, any suspicious nodes must be removed regardless of mapping. And if there is no mapping or any hemipelvis, or in case of only unilateral involvement, so site-specific lymph node has to be performed. The parametromy is performed en bloc with the resection of the primary tumor. Now, of course, with this advent, with the newer version, the newer technique, and there is shift of practice from MIS to open, because there are certain trial which has been observed earlier. Many laparoscopic has to be done in case of cervical cancer, and then many things which has seen. So now from laparoscopy, again, it has come to open. So there were many trial with this context, and that is called LAC trial, because that update in 2019 in case of ESCO 2019, they say that disease-free survival was almost 84.2%, and the overall survival was 77, although it is a non-inferior trial, and it is found that the open is much better than the laparoscopic in this trial. So the question which is arising out of this LAC trial is the laparoscopic has a better outcome or a open. So a randomized trial is statistically larger than the LAC trial has to be done because it is a inferior trial and it requires precisely the effect of MIS has to be labeled and documented. So the LAC trial was neither powered nor designed to answer this question. So that is a question mark which has remained. The other studies like which has been given for this regarding the open and the uh, uh, the laparoscopic. So also they have said the use of manipulator while doing laparoscopic was associated with the worst disease-free survival in case of laparoscopic group. So nowadays it is not recommended to use any manipulator while doing laparoscopy. And also the minimally invasive compared with open hysterectomy resulted in a similar lower incidence of intraoperative or a postoperative adverse event. And regarding the quality of life in patient with such undergoing open and laparoscopic, it is found that it is found that it is almost same. There is no any difference in the quality of life. So now with the advent of robotics, so there is also a robotic assisted approach to the cervical cancer, and that is RAC, which is an international multi-center randomized trial. So it started in 2019. So the primary endpoint was to see for the disease-free survival 5 year. And of course, other secondary outcome like overall survival, complication, and the quality of life and the diagnosis accuracy. So what are the consideration for fertility sparing surgery? First of all, we need to, it is not the job of only one surgeon, but yes, we need to involve all the multidisciplinary team, that is including a fertility specialist, the patho-oncologist in this aspect, so that we can consult and discuss and decide regarding the fertility sparing surgery and its management. And of course, the histology has to be identified, the tumor size, proper staging, proper radiological staging, and also the involvement of the lymph node, so that we can decide whether we can go for sentinel node or removal of the removal of the whole lymph node dissection, and also whether it has to be radical surgery or just a simple surgery. And if so, the outcome, the pregnancy outcome, the future outcome has to be considered in case of when the patient get conceived in future. So the fertility sparing surgery, depending upon the cervical tumor, the stage, it can be, I have discussed earlier already, it can be conization trachelectomy, and in case when we think about parametrium removal, it can be trachelectomy with either a simple or a radical. So this is the large conization, and this is the where we can remove a little bit of parametrial involvement of the node, then we can go for radical. So what are the aspects of follow-up such patient when they are going for fertility sparing surgery? So monthly, at least 3 monthly pap smear for at least 2 years, and then 6 monthly for next 2 years is almost recommended such patient. And of course, the counseling, the proper checkup as per the oncology guidelines. With normal follow-up at 5 years, the patient can return to the routine screening schedule according to the national guidelines of cervical cancer screening, and other tests like imaging has to be recommended. Not recommended routinely, sorry, but may be performed because to see for any lymph node status. So there are others regarding the neoadjuvant chemotherapy followed by fertility sparing surgery, not removal of the surgery, but the tumor is there, we can go for neo, but that is Contessa trial, which is still coming in. I'll just go on with this. So what is the role of surgery in locally advanced and recurrent disease? So what we have discussed is everything about the conservative, the need for radical, the need for simple surgery. But what about the local advance, especially the post-radiation? What we have encountered after radiation, they come with residual disease, they come with complication, bleeding, and all those. So what the guideline says, yes, the surgical debulking of enlarged lymph node, no. If there is any routine paraortic lymph node staging in advanced cervical cancer, then no. If thinking of palliative intent, in case of reversion, if there is presence of fistula or maybe recurrent complication of post radiation, then we can, or maybe coming with malignant or bowel obstruction, yes, we can consider. But yes, after doing this surgery, the morbidity, the quality of life is such a irritating and very difficult for the patient, especially the low socioeconomic group of patient, because it is not about the morbidity or related to this exenteration operation, but the financial outcome, the financial the extent for the patient, the use of colostomy bag, the use of the ileal conduit bag, and also the family burden with this, coming to the regular follow-up for the patient to the hospital. I mean, it is really a physical and the mental torture for the patient, because we have seen such patients, they go for exenteration surgery, we think, okay, we are doing a good thing, good job for it, but no, actually they are suffering from such kind of surgeries. So I think we have to really counsel, and we have to think we're going with such advanced care surgeries for the locally advanced cervical cancer, and especially with the residual and the recurrent cases. So with this thing, I'll finish my talk, and thank you so much for listening to my talk. And first of all, before finishing, I would like to, because we since working in the Cancer Institute, it is many of our colleague, non-gynae colleague, they say your cervical cancer burden, the cases have been decreased. Yes, that is true. We are operating less cervical cancer cases because we are dealing with more advanced cases. So they think because of the cervical cancer screening we are involved, we are HPV vaccination, we are decreasing the cervical cancer cases. No, absolutely not. The cases are still same. In fact, it is increasing. And secondly, they are coming in a late stage. They are presenting to us. And thirdly, what we can see, the most of the peripheral, the doctors, the gynae doctors, which are practicing maybe in the medical colleges or maybe in peripheral, sometimes what I have said that earlier in my talk, the proper diagnosis, the proper staging is very important. So sometimes they do go with maybe radical hysterectomy, and then they come out with the advanced case of cervical cancer, and then they require either they come with that subtotal kind of hysterectomy. Sorry to, I mean, it's very a sad part of to say that being working in a cancer institute. And sometimes if they go with a proper surgery, the radical surgery, but pathologically it comes as advanced cases, and then require the second modality, that is radiotherapy in such patient, and that increases the morbidity. So with that, I will finish my talk here. Thank you so much for this. Thank you.
Thank you, Dr. Manisha. It is an excellent presentation covering almost the detailed aspect of the surgery that the patient needs to do. And what you stress here is the proper staging is important before you decide what to do.
Absolutely.
And yeah, this is very, very important. Proper staging, and you are to plan what surgery exactly the patient will require, or else will go for something else. And it's very painful when I listen that some of the surgery which are carried out, which is a half-hearted surgery, then you have to complete subsequently. This should not happen. This should not happen. Yeah, this I think this should not happen. And when one particular gynecologist, we are a little careful, probably that can be avoided. That can be avoided. We should be more careful before you put up the patient for a surgery. Yeah. And this is very nicely you have stressed. We should not put two modalities for a lady. It becomes very difficult for the lady to tolerate both the modalities of treatment.
Yes,
However, Dr. Manisha, it is an excellent one. Thank you very much. I am happy to participate in the session as chairperson. Thank you. Thank you very much.
Yes, Monica. So, can I speak for 2 minutes?
Yes, ma'am. Sure.
Yeah, Monica, it was a very, very excellent presentation.
Thank you so
thank
much.
you, Dr. Pranay, for actually appreciating Manisha. So I think as you are in a medical college, sir is in a medical college. So actually, sir, it is a request from my side that actually we were also planning that initially actually when we were young in every medical college there was one person who was able to do radical hysterectomy. Now everyone has shifted their focus to laparoscopy and infertility. No one is interested to learn radical hysterectomy. So I
Very
think
true,
it's
ma'am.
not
Very true.
a very difficult surgery. I think people.
I am an old surgeon, and I am having a lot of experience of carrying out the radical surgery, and that too often. So I am happy
I
to
think we
share
have
it with
to
you.
stimulate our younger generation, especially those who are
Yes.
in medical. If every medical college has one person who can do a radical hysterectomy, we can train 10 people who will be coming out of the medical
Absolutely.
college.
Absolutely, ma'am.
Okay.
Absolutely.
I think yes, we can try it out as a project and see what can be done.
Ma'am, with that, what we are seeing nowadays, yes, they are going the surgery, they are undergoing surgery outside by a trained gynecologist, in fact, or I would rather say. But now they are presenting to us with a scar metastasis. They are
Yeah.
going, there is no local, but they are coming with the scar metastasis within 4 to 5 months. We have collected many, 1 year, we have collected almost 10 to 12 cases coming with the scar incision metastasis. So that is a very surprising and a very I'm a unfortunate thing we are seeing. And directly patient goes for palliative type of chemotherapy. I mean, followed by, of course, radiation. But I really don't know, the burden of cervical cancer is becoming so aggressive nowadays. It is not just a cervical cancer screening and the surgical management, but also I think the aspect, the proper diagnosis, the proper staging. I sometimes being in the institute, we have a DNB super specialty student. They don't get a surgical case, cervical cancer case to
Yes,
operate a
yes,
radical
yes.
hysterectomy. So sometimes I
I
was
think
like,
when
why?
we start
Because of the 2019,
screening,
18 staging. But somewhere it is somewhere good, 2018 has changed the aspect, the dual modality, and patient is actually getting a good kind of the prognosis and the outcome with this staging, of course, because earlier is to get surgery followed by radiation, so much of, I mean, then they're coming with the post radiation complication. So that was a thing to be considered.
But Manisha, I have never come across a patient following radical surgery. I am here, we are having a cancer institute also with scar metastasis. This I have
Yes.
never seen.
I don't know. That's what we are also surprised. Really, we have operated here. We are doing in a Chittaranjan National Cancer. We are doing extraperitoneal lymph node dissection. Dr. Mondal, Dr. Ranjit Mondal is here HOD. So we are doing, but we never encountered any scar mets. But nowadays we are seeing a scar metastasis, fenestrial incision, and there are metastases over the scar within 4 to 5 months of post surgery. I don't know what is the reason. Is it because I really don't understand? I mean,
I have never come across such
we
type of
have the
patient.
pictures, and I mean and we have proving it by the biopsy and all.
Yeah, you can keep this series and
we are doing
put
it,
it up
sir.
in the National Congress.
Yeah, we already presented. Let's see.
Yeah.
Thank
Fine.
you, sir.
Yeah, thank you, Dr. Manisha.
Thank you, Manisha.
Yeah, thank you so much.
Yes, thank you, Dr. Manisha. That was indeed a lovely presentation. Really, it was so great to hear you. And also thank you, Dr. Pranayanath sir, and thank you to Bhagyalakshmi ma'am for your expert comments. Before moving on to our panel discussion, we would like to have a few words of blessings from Dr. Shamal Seth sir, if he's there. Sir, are you there? Shamal sir? I guess he had joined and he must have left. Okay, we will move on to our next session then. Our next session is next academic session is the panel discussion on screening methods and vaccination in cervical cancer, along with a couple of cases which Dr. Ashok Padi sir wanted to discuss about the management modalities of cervical cancer. Our moderators for the session are Dr. Asha Jain ma'am and Dr. Rekha Jha ma'am. Can we have the slide of Dr. Asha Jain, please, Abhishek? Yeah, Dr. Asha Jain, ma'am, is currently the director of SMSA Hospital, Raipur. She is also the medical director at Cancer Prevention and Relief Society. She is also the vice president of IMA Chhattisgarh, and her various fields of interests are saving the uterus, fetal medicine, obs and gynae, ultrasound, critical care, and preventive oncology. We welcome you, ma'am. Our next moderator is Dr. Rekha Jha, ma'am, our very own Dr. Rekha Jha. Dr. Rekha Jha, ma'am, is currently the president of Bhagalpur Obstetrics and Gynecological Society and also the East Zone coordinator for the Public Awareness Committee of Fogsi. She is the scientific chairperson of IMA Bhagalpur as well as the past secretary and past vice president of IMA Bhagalpur. And she is a member of various societies. We welcome you, ma'am. Our experts for the panel discussion are Dr. Hemali Sinha ma'am and Dr. Ashok Padi sir. Dr. Hemali Sinha ma'am is the professor and head in the Department of Obstetric and Gynecology at the All India Institute of Medical Sciences, Patna. Her various professional interests include maternal fetal medicine, obstetric epidemiology.
Thank you, madam. I think we can move on.
Yes, ma'am. Welcome you. We welcome you, ma'am. And our next expert panelist is Dr. Ashok Padi, sir. He is a senior assistant professor in gynae oncology at AHPG Institute of Cancer at Cuttack, Odisha. And also he has a fellowship in advanced gynae oncology from Roswell Park Cancer Institute in USA. And he was the one to perform the first robotic gynae surgery in Odisha. We welcome you, sir.
Yeah. Thank you, ma'am.
Yeah, we have a gamut of panelists over here, all experts in the field. Monica, are you there?
Yeah. Yes, I'm there, Shita.
Please take over. Yeah.
I take privilege in introducing a galaxy of star of panelists here. Dr. Sindhu Bala madam, Dr. Mukta Agarwal ma'am. Dr. Sindhu Bala madam is a clinical director of the Creation Fertility Center at Siliguri. She is a consultant at Arogya Niketan Nursing Home and Negosha Gateway, Siliguri. She has done her PG from PGI Chandigarh. We welcome you, ma'am.
Thank you.
Our next panelist is Dr. Mukta Agarwal madam. She is an additional professor and unit head at the AIIMS Patna. She is a gold medalist at both undergraduate and postgraduate levels. She has more than 45 publications to her name in index journals. And she is an dissertation reviewer, an undergraduate and a postgraduate examiner. We welcome you, ma'am. Our next panelist is Dr. Jitendra Kumar Panda, sir. He is the president of Bhubaneswar OBGYN Society. He is the president of IIB Bhubaneswar too. He has published papers in international journal and local magazines, and he's a senior gynecologist in Bhubaneswar. We welcome you, sir.
Thank you.
Dr. Kavita Barnwal, ma'am, is a senior consultant and laparoscopic surgeon at Samarpan Hospital, Munger. She is also the recipient of Padma Bhushan Karnala Hospital Award. She has been the member of ITP Committee Fogsi in the year 21-23 and received the Champion Award twice. She is the organizing secretary of GS Bhagalpur, life member of various institutes.
I think we should move forward.
Yes, ma'am. We welcome you, ma'am. Our next panelist is Dr. Sangeeta Thakur, madam. She is a practicing consultant at ISER Nursing Home. She has performed more than 10,000 surgeries, including the 5th cesarean section, and she is the secretary of Saharsa OBGYN Society currently. We welcome you, ma'am. The next panelist is Dr. Salam Sheila, ma'am. She is the assistant professor at Department of OBGYN in the RIMS of Imphal, Manipur. Her areas of interest include fetal medicine, reproductive medicine. She has been trained in obstetric ultrasound, and she is a member of various ultrasound bodies. We welcome you, ma'am. Our next panelist is Dr. Indira Palu, ma'am. She is the associate professor at NKCG Medical College, Behrampur. She is the secretary of Behrampur OBGYN Society, and she has secured the first rank in her undergraduate and postgraduate levels. She has published many articles in national journals. We welcome you, ma'am. Our next panelist is Dr. Anju Singh, madam. She is the director of Baichanath Nursing Home and Research Center. She is the founder, vice president of Sita Mavi OBGYN Society. At present, she is the president of the same society. She is a life member of various associations, and she has many national and international lectures to her credit. We welcome all of you for this panel discussion. Asha ma'am and Rekha ma'am, you can take over.
Thank you, Dr. Monica. I was just asking whether Dr. Padi wants to show his cases first.
Yeah,
because
definitely.
he will be talking on cervical cancer, right? And we will be talking on screening. So in continuation with treatment, he can finish that.
Okay, ma'am. No issue. If you want, and can I say the screen?
Yes, sir.
Yeah.
So how much time would you take? Padi, sir?
Yeah.
Ma'am, sir has 2 cases for discussion.
Only 20 minutes. 20 minutes to 25 minutes maximum. Dr. Monica is there?
Yes, I am there, sir. Asha, Abhishek, can you please share the PPT that I have sent you?
Okay, actually, sir has shared the screen.
Yeah, you can allow sir to share the screen. If that is not possible, then you share the PPT.
I stop sharing. So, Dr. Abhishek, can you share it for me?
Yes, sir. I'm sharing.
So share it for me. Just I will take only 20 minutes. This is all about two cases I want to discuss because this is the real life scenarios what we face in our day-to-day practices about this how we manage cervical cancer.
हो गया 10 करोड़
10 lakh हो गया
Sir, screen shared.
Yeah. So nice. Thank you so much, Dr. Abhishek. So should I start?
Yes, sir.
So, all our experts and all the panelists, a very good evening to all of you. So without wasting time, let's start with the first case. This is case 1. So next, can I have the next slide, please? Yeah, this is a real life scenario. That is a 43 years para 4 lady come with a history of contact bleeding since 4 months, and her attendant come with a cytology report of NILM, which was taken outside. So I was sitting in a VG OPD and she came with a report showing NILM on a smear. So what next? So this is a question to discuss. So Dr. Sinu ma'am. So in that case, what? Yeah.
Yes. I would like to go for trias. She is having a cytology report and symptom which is not like, correlating with each other. So I'll ask her to get a PAP, not PAP, actually papillomavirus DNA test, and preferably do a colposcopy and colposcopy guided biopsy to see whether all the spermocolumnar.
Can I have the next slide, please, Avisa? Yeah. So
this is the probable cause of discrepancy. This is the her colposcopy report, right?
That is on visual inspection. That is not on colposcopy. Actually, just let me tell the truth. The patient's attendant come with a report of an ALM. Then I asked the patient, the attendant to tell her patient to come. The next day, the patient has come, and this is the on visual inspection. The cervix looks like that. So, what are the most probable cause of this discrepancy? Why such things happens? Because there is a report saying NILM, and you are saying a lesion on visual inspection. So, what might be the probable cause?
Because we know that cytology has got too much of false negative. It is not very highly sensitive report. So the person who has taken, how he has taken, whether it was taken by a sister or a doctor, whether they have missed the area, whether the cytology report has been read properly by an expert doctor, it all depends, because we know the cytology is very much misleading. It is not very highly sensitive. Of course, it is specific. So there is chances of missing out sometime even an invasive cancer. So we have to do a triage in such cases. We have to go for a colposcopy and preferably colposcopy guided biopsy and take a larger chunk. Here I can see that her transformation zone is quite like type B and it has gone inside the canal. Yeah. So this patient needs a proper colposcopy and colposcopy guided biopsy and then further treatment.
Yeah. So probably it may so happen that the smear might be taken from the necrosed area with this kind of cervix. So that might be also causes. Doctor, actually, when I inquired, I found that this was taken by a sister in the periphery, and they have sent the report. They have sent the slide to this our hospital, and that came to be an ALM. Can I have the next slide, Dr. Abhishek? Yeah. So how will you manage this case? Next.
Are you asking me?
Next. These are all animations.
Okay, so actually, can I say? So I think we will go for colposcopy and then we will see the biopsy report. So what the biopsy says, then accordingly we will decide. So if the biopsy confirms it's invasive cancer or high-grade squamous intraepithelial lesion, then and the patient is 38 years old and she has completed the family, then we can offer her hysterectomy, because in our areas they can't come for a repeated examination and repeated checks. So if there is chances of HSIL or invasive cancer, then we can offer for hysterectomy. And what is the staging of the cancer, that we have to see.
Yes, very true. Yeah. So all options just I have told, that is anything else. So can I have the next slide, please? So we did colposcopy and directed biopsy. Next. And the biopsy source, just previous. It is invasive squamous cell carcinoma. So any extent can be possible. We have a broad range, something coming with NILM. Later on, if you do a colposcopy and found invasive squamous cell carcinoma, and all the discrepancy occurs. And if you are sitting in the BG schedule, you may miss. You may tell the patient, hey, you have NILM, go up and have permanent routine spinning. So it is actually not about the thing, because many times you have to look the cervix. That is very important. So if the patient comes with a report of such things, at least you say this attender to come bring the patient for the next session, and you see the patient, have a spot speculum examination, and clinically evaluate patient first. That is most important. Can I have the next slide, please? So many times such scenario arises in a busy UPD, patients, relatives, attendants come with this sub-report. As a clinician, clinical evaluation is very important. It is not TPS, Delhi Public School. it is do for speculum examinations. I'm giving more stress on that. So at least how many of the gynecologists of this country do a for speculum examination with such kind of symptoms? That we have to introspect. That is more important. But at this juncture of time, what I want to give a stress, the message to the audience, message to gynecologists, practicing gynecologists, at least do a for speculum examination. Next, can I have the next slide? Then how will you evaluate and plan the management? How will you stage the disease? So, ma'am, Mukta ma'am.
Carcinoma is clinically. It's
Yeah.
always clinical staging. And
Yeah,
in this case, biopsy is available. I do not know whether it was a cone biopsy or a punch biopsy. We
It's a
have
punch
to
biopsy.
see the depth. It was a punch biopsy. So the depth of invasion, since it is saying invasive squamous cell carcinoma, the depth of invasion must be throughout. And the lesion extent, I can see it is like more than 4 centimeters. So it qualifies to the grade 1B.
Yeah.
So further treatment will be decided like patient party. Of course, we can offer her like if facility is there for complete, we have to go for a lymph node biopsy, and if facility is there for complete, radical hysterectomy, then we can offer that. Is it 4 centimeters or less, Dr. Saab? I could not make out because it was not.
Can I have the next slide? I'm coming for that. So what I want to give a stress that is proper clinical evaluation, including for speculum and bimanual examination, is mandatory to stage disease. And after 2018 FIGO staging, the staging is not only clinical, it is clinico-pathological and imaging guided. Because these two things, pathology and radiology, has come into integrated in the previous, that is 2008 FIGO classification of staging, and now it is a clinico-pathological imaging. And confirmation diagnosis is histopathology, and you should ask the pathologist to give the diagnosis as per WHO histological classification, especially mentioning the SPB associated and SPB independent cervical cancer that we have discussed by Dr. Bhagyalakshmi also. So next, can I have the next? So it's about 1V2 lesions. 1V2 lesions, ma'am, then Sindhu ma'am, can you tell what investigations you want to do, particularly in this case?
Yes. We have to see the possibility of extent to the nearby structure. MRI can, of course, be very helpful in such. And since you have already told it is 1B, that means it is localized to the cervix. But still, we have to be sure, and we can be sure with imaging modality, especially the MRI, which can tell us whether there is hydroaerator, hydronephrosis, thickened parametrium, enlarged lymph nodes. These are the silent marker, like, the surrogate marker for possibility of invasive disease, much beyond than 1B. It could be, 2A as well. Beyond the cervix.
So before taking to this type of patient to OT, so what we have to do? Proper investigation.
Yes, sir. Actually, liver and kidney function should be tested before going for a surgery, and even X-ray. And I think PET CT also should be done, whether she has advanced disease and there is metastasis to distant past. So all these things, cystoscopy should be done, whether there is any involvement of the bladder also, and also proctoscopic microscopy. Before deciding for the surgery, we have to rule out all these things. What is the extent of the disease and what are the parts which has been involved till now? Then only we can plan the surgery, and then we can discuss with the patient and her attendant.
Very true, very true. So actually, ideally, MRI and CT scan are the two important modality that is required. MRI is superior to CT in actually identifying the tumor size, parametric extension, and the extent of nodal disease. But if you have not the MRI and CT scan of things, you can go for ultrasonography, which as a basic modality before starting the treatment. So can I have the next slide, please? So the staging is clinical and need to discuss next. So next for the second case. So can I have the next slide? This is Mrs. R. Postmenopausal. She complained with the postmenopausal discharge for 3 months. She is para 12-2. On examination, cervix is small. There is a polypoidal lesion of 1 into 1 centimeter at the external lobes, especially near the anterior lip. And when you took biopsy, the real-time PCR is HB positive, and the genotype is 60. Next. So this kind of things on phosphospeculum. And next. Or biopsy shows that is a microinvasive cancer. Next. So what is microinvasive cancer, cervix? Jitendra sir, can you put some light on that?
Yeah, yes, sir. Macroinvasive disease that is not visible, the naked eye, and it's only diagnosed with biopsy, and it depends what is the extent of the disease. Whether less than 3 millimeter in depth, then it is stage 1A1, and if it is 3 to 5 millimeter, then it is 1A2, and if it is more than 5, then it is 1A3. So depending on whether there is limb vascular invasion or not, that will decide what type of the disease. So macroinvasive
Madam, there is no 1A3, 1A1 and 1A2 are microinvasive. Previously they're thinking, but after this 2023 NCCN guideline, microinvasive cancer is defined as because stage 1A1, that is less than 3 mm with no LBSI. So this is the modern definition of microinvasive cancer service. Next. So we did MRI. Next. But the MRI shows there is a lesion. If you see the MRI, analyze the MRI, you will see there is a special growth, a specific growth which is noted in the anterior lip of cervix, predominantly on the right side, without any bilateral parametric involvement. And fat tails between this lesion, that is in the anterior lip, between the bladder, is well maintained. You see, you can see there is the fat tail is well maintained with bladder. Next. So observe the cervical ring, that is the cervical ring is not broken. That means that it has not extended to the parametrium. So parametrium is not involved. Next. So this clinically, what I see observed on biopsy taken by somebody, it comes to a microinvasive sensor. That is stage 1A1 type of thing. But when I saw, I get a lesion of around 2 into 2.2 centimeter, which is clinically stage 1B2 cervical cancer as per people. So how will you treat this kind of cases? So anybody can take this question. Kavita ma'am?
Yes, sir. Yeah. So this is stage 1B2, na? So we will go for radical hysterectomy along with the lymph node dissection.
Which type of radical hysterectomy?
I think the stage 2 should be done in that case, involving the whole of the uterus, part of all of the lymph nodes, including cervix, and whether involvement there 1B2, na? So
yeah, 1B2.
Yeah, so I think vagina is not involved. So we will go for, I think, along with the lymph nodes, pelvic lymph nodes, and if there is a possibility of frozen section, then we will do that thing also. Otherwise, we will go for pelvic lymph dissection along with the hysterectomy. And bilateral, definitely bilateral salpingoprectomy.
Suppose your frozen comes to be positive lymph nodes, then what you will whether to go for lymph node dissection first or whether to go for hysterectomy first?
Then we will go for lymph node dissection.
And if it comes to be positive,
then we will do
proceed or to abandon the procedure then and there.
थोड़ी देर में बात करूंगी ठाकुर. एक सेमिनार चल.
Anju ma'am, are you there?
Yeah, Mukta.
Yeah.
Mukta
So, for me, for these cases, as I'm a laparoscopic surgeon, I put the laparoscope and I first do lymphadenectomy and send for frozen section. If lymph nodes are positive, we abandon the procedure and send the patient for radiotherapy, as we do not want to have the dual modality of treatments and dual morbidity for the patients. And if lymph nodes are negative, then we go for this radical hysterectomy. For this case, preferably type 3 radical hysterectomy.
Open or minimal magic? Which method? You are a laparoscopic surgeon, that's why I'm asking.
Yeah.
Which
yeah,
method?
honestly, I'm doing laparoscopic only.
So you will go to laparoscopic type 3 kind of surgery.
Yeah, we are doing laparoscopic type 3 surgery, but once we get the report of lymph nodes negative.
Even after the LACC trial?
Yeah. Even after LACC trial, for these stage, we don't take, our selection of cases are like that we don't take any tumor that is more than 2 centimeters.
Yeah, but here it is more than 2 centimeters. That's why I'm asking.
Yeah, we don't. We select our cases very carefully, and we always try that our patient should not go into dual modality of treatment. Usually, for these cases, we select microinvasive cancers only after having a clear parametrium in MRI. Then only we proceed, and frozen section for lymph nodes before proceeding for hysterectomy.
So very nice. So after this lymph node staging by your laparoscopy route, if you get a positive, then
Padi sir, we have a great deal of work to do in screening and vaccination.
Another 5 minutes, 5 to 10 minutes maximum.
Sir, it's already half an hour.
Not happen. So just 5 minutes. I started in 6:45, 6:40 around. Okay, 5 minutes. So in OT, what you will do before surgery? Just one message I want to just ventilate here. What in OT, what you will do before surgery? Because many times what happens when you say stage it is a 1B2 disease, but what happens, there are some skip lesions in the vagina. So what you do actually, usually you should go for a BIA in the OT before starting the surgery, so that you can miss out some, you will not miss out some lesions if it is in the vagina. So there may be skip lesions. Okay, next slide. So stage-wise surgical management already discussed by Dr. Manisha. I'm not going to keep more stress on that. Next slide. Next slide. Abhishek. So types of hysterectomy, again, it was discussed by the two methods, that is fibroclase and Corlumoro. So we all know about that. Next. So she was planned for type 3 kind of radical hysterectomy. Next. Next. So type 3 radical hysterectomy was done and systematic bilateral pelvic lymphadenectomy was done along with paraortic lymph node sampling. Next. This is the specimen. Next. And the cross section shows 3 into 2 centimeter of endocervical canal. So that was confusing because when you took the biopsy from anterior lobe of cervix, it comes to microinvasive. So my point to give stress on that, because many times what can happens, you may get a microinvasive cancer in the histopathological world, but you have to go for take the help of MRI, because after the FIGO 2018 staging, you need to take the help of MRI and imaging facility. And again, you see it clinically if you're getting lesions, because the staging is clinico-radiological and pathological. So if you're getting it big lesions, so don't rely on the only this pathology report. So you accordingly decide, and this is the you get an endocervical lesion of 3 to 2 centimeters. Next slide. Next. So how to differentiate between endocervical cancer and endometrial cancer? Stage 2, that is with the endocervical extension. You can ask your pathologist to check for ISC, maybe particularly P16 and Ki67. If it is positive, then it may be endocervical cancer. And if it is endometrial cancer with endocervical extension, in that case, you'll get a ERPR positive and thymidine positive for P16 and KCI67 and negative. Next. So I will do decide for adjuvant treatment following surgery. So anybody can take shortly.
Such patient will need follow-up, like as Madam has already said, 3 months after the surgery.
Yeah, that's nice. But how to decide for adjuvant treatment? Okay, can I have the next slide?
First, we see the
depending upon the lymph node, sir,
Yeah,
depending upon the lymph node involvement.
Yeah. So you
What
discuss
is the
depends on
Parametrium or 3 margin. 3EP.
Yeah. That is LMP. If the 3P is positive, for high risk, there are high risk factors. These patients, any one of the factors is positive, these patients require concurrent chemo radiation. There are some group of patients that intermediate risk factors. If you are getting a presence of LBSI or tumor size more than 4 centimeter or stromal margin more than 50%. If any two are present, patient needs adjuvant radiotherapy. And all other patients, they do not need any adjuvant, but they need regular follow-up. Next, can I have the next? This is the follow-up schedule. That is every follow-up every 3 to 4 months for 2 years, then every 6 months, the next 3 years, and every yearly thereafter. Next. Thank you so much. Over to Dr. Asa, madam. So she was worried. So we can have to discuss all the screening by Dr. Asa. Over to Dr. Asa Jain, madam.
Thank you, Padi sir, for winding up so fast. But actually, this is a really very, very big topic. And this is where most of the gynecologists can help. Screening is what is going to prevent all those cancers. I just heard our last speaker, and she kept saying that, whatever people say, there is a lot of cancer that's coming in, and it's so advanced. So let us start with this. I thank the organizers. I thank Dr. Bhagya and Dr. Monica for giving me this opportunity. I'm delighted to be in the Northeast. So these are my panelists. You've already heard about them. Now, my first question.
Ma'am, can you make the screen full? Yes, ma'am.
So my experts are Dr. Himali and Dr. Padi sir. And I'm going to ask a first question. What is the incidence of cervical cancer in the world? What's the incidence?
Me? You are asking me, ma'am?
Yes, ma'am, you go ahead.
Yeah,
Actually, I
okay.
haven't assigned anything to anyone. Anyone who knows can just start.
Incidence of cervical cancer worldwide.
Yes,
Its
ma'am.
annual incidence is more than 5 lakh, I think 5 lakh something annually, and death occurs about 2,20,000 annually. In India, India contributes 23% of total cases of the world, and it accounts for 25% of all deaths. In India, about 1,22,000 cases and 67,000 per year death.
Ma'am, that 67,000 figure has increased now. And you can see that we are still in the red in the mortality. It's a disproportionate number of deaths that we have. So thank you very much for that answer. And can anyone say why we are having this discussion today? Why are we even talking of screening and vaccination?
Just to get rid of the disease.
Hello.
Yeah.
Hello. May I answer this one?
Yes, yes.
Yes, ma'am.
Ma'am, the cervical cancer is the fourth leading cause of cancer worldwide and also the fourth leading cause of mortality worldwide. And however, it is a cancer which is quite preventable by adequate screening methods and treatment of precancerous lesions. And also nowadays with the availability of vaccines, if we are able to catch hold of young adolescent women, even boys, if we vaccinate them properly before 15 years of age, then it is a cancer which can be eliminated as a public health problem. That's why I think it is one of the cancer which is quite preventable, and we will be able to reduce lot of disease burden in the worldwide by these things. Hence, an awareness among the gynecologists and general public is very important regarding this cancer.
Thank you, ma'am. So actually, the chief of WHO put it very succinctly that one woman dies of cervical cancer every 2 minutes, and it is a preventable disease. Each one is a tragedy, and we can prevent it. So we are having this discussion today, how to prevent cervical cancer. WHO intent. Can anybody talk about it? What is the intent of WHO, the position paper?
To eradicate by 2030, but yeah.
90-70-90.
90% of girls should get vaccine, 70% should be screened of the population, and 90% should get treatment in the early stage disease.
So this is what we have recited. But my panelists here, most learned panelists, do you think it is possible in India?
No, not now. Not now. What is the scenario in our country? It's not possible at present.
Unless until government incorporate in their vaccination program to vaccinate all eligible girls at the school level. It has to be like government mandated. Government has to commit it for it.
But still,
so we will come to that
madam,
now.
actually, they don't have facility for screening. Yesterday only I saw a patient who came with the pyometra, and there were no external growth, and she was looking for these things. Only she had complaint of contact bleeding. And yesterday she came, and when I did TVS and when I did examination, I found there was pyometra, and the growth was not visible outside. It was in the endocervical canal. So that case was posted by me also. So I don't think this by 2030 we can eliminate cervical cancer completely. It will take some time.
There are 3 strategies, ma'am. So the 3 strategies as shown by WHO are that there is primary prevention, where we are talking of vaccination of young girls. Then we have secondary prevention, which is screening and treatment. And then we also have tertiary prevention. Now, tertiary prevention has been spoken of in detail. Lots of hospitals are coming up. Today, we are going to focus here on primary prevention and secondary prevention. So what are the causative factors? What are the causative factors of cervical cancer? It's only when we know that these are the causative factors that we are going to be able to deal with it.
Early marriage, polygamy, lack of hygiene, lack of use of condoms, sexually transmitted diseases, immunocompromised women in HIV, and even herpes simplex virus that can also cause inflammation of the cervix. And these are the factors which can lead to increased incidence of cancer. So even OC pills, smoking, all these factors can lead to increased incidence of cervical cancer.
Dr.
Immunocompromised
Susie, would you like to add something?
Their HPV causative factors are HPV related and non-HPV related. So anything that increases
What
HPV.
we have to understand is that HPV
yeah.
is a necessary cause. You need to have HPV in 99.9% of cervical cancer. And then all others are contributory causes. So it is because it is a virus is causing it, and we have the vaccine, that we are talking about prevention. So ma'am mentioned everything else and she forgot HPV, which
no,
we
madam,
really
actually,
need to
no,
remember.
madam. HPV, I think many of us get infection, but it gets, I think, ruled out because of these absence of these factors. So HPV infection, naturally, this is most important. We are talking about the vaccination. Yeah.
HPV infection is a necessary cause. This is what I want my respected panelists to discuss a bit right now. What do we really mean by necessary cause? Sindhuwala ma'am, would you like to say something?
Yes, ma'am. Actually, it is HPV DNA which gets incorporated into that transforming cervical zone, and it starts multiplying. And whatever the factors, they are the already written down, which predispose them to turn up into CIN1, CIN2, and CIN3. A prerequisite is HPV infection with intercourse or during other activities also. And the adolescent is
actually, let us just speak about why it is a necessary cause. What do we mean by that term necessary cause? Jitendra sir, aap kahenge?
Well, it's now very well known since the Harald Jor Hassan discovered that HPV type 16 and 18 are the primary cause of cancer cervix, and that is why he got the Nobel Prize in 2008. So all these things are our predisposing factors, but the main causative factor is the HPV.
Yes.
6, 11,
so now we
6,
have
59.
HPV of more than 200 varieties, out of which there are about 18 which are high risk types, and out of which most important is
16 and 18.
And 18,
which is responsible for 70% cases. Yeah, that is
exactly,
responsible for 70%.
exactly. So now we will talk first on primary prevention. We are all gynecologists. A lot of us are cancer practitioners. So I will not be going to basic science. What I'm going to talk about is, we are talking about primary prevention. What are the available vaccines? In India, what vaccines do we have right now?
Gardasil we have another. Today I got one vaccine that is manufactured by Serum Institute. So it's available at a lower rate. That is also quadrivalent vaccine, 16, 18, 6, 11. So I think that is today just I know that this vaccine is being manufactured, and many states have incorporated in the government program also, though it's not included in our state. But
Anju ma'am,
Gardasil.
Anju ma'am, would you like to add something to it? Dr. Mukta, would you like to add something to that?
Yeah, thank you, ma'am. So we have bivalent vaccine in the name of Cervarix. The quadrivalent one.
Bivalent is not available anymore.
Not
it's
available
gone.
in our part. Only Gardasil is available, and today I got
It's not
Sababa.
available anywhere. They have stopped manufacturing it.
So Gardasil is available. Gardasil 9 has come newly.
Gardasil and the single dose vaccine, which is this Gardasil 9.
9, yeah.
It's not a single dose vaccine. Today we are going to deal with all those myths. Okay. So what do we have? We have quadrivalent vaccine, which is by MSD and also by Serum. The licensing is different. The licensing of the MSD vaccine is 9 to 45 years. It is also licensed to be given in lactating period. The serum vaccine is 9 to 25 years. No license for lactation. Nanovalent vaccine, again by MSD, is 9 to 26 years. It is licensed for both sexes. So one more line, Himali ma'am. Himali ma'am,
yes.
Would you like to say something on the therapeutic and prophylactic aspect?
Well, these are used for prophylaxis at a younger age group before the girls are sexually active. But once they are sexually active, even then it can still be given because it will be against these stereotypes, but they're required to be given to these women again also. So, I mean, it's not really therapeutic, but it should be, it is supposed to be given before girls are sexually active, but it can be given to women who are also sexually active. So they are prophylactic.
One more thing that I want to ask, that if they are given after sexual activity, now you're giving it to a girl between 9 to 15 years,
yes,
and you're giving it to a woman who's 40 years. What is the difference in efficacy?
They're required to be given one extra dose.
And screening screening should be done in women who are sexually active as usual.
Continued anyway. Screening requires to be continued anyway, and they require one extra dose.
No, ma'am, they do not require one extra dose. They do not.
Screening should be done, I think. Yeah.
But the efficacy against CIM decreases to 90% compared to 94%. Okay? 100% efficacy against the viruses included in the vaccine if it is given in the young age. This will go down to 90% if it is given at 40 years of age. And there are two factors. One is the immunogenicity of the immune response of the host becomes less. And also the second thing is that the person is already exposed to the virus, then it is not therapeutic, it is prophylactic, and it will not make antibodies against the virus which has already been exposed. We require 3 doses in adult women, that is 0, 2, and 6. We do not need a 4th dose. We need 0, 2, and 6. What is the current dosage schedule? This is as per WHO paper which Dr. Partha Basu presented at Eurogen this year in February. So anybody can answer this?
Yeah, madam, but till now we have got between 9 to 14 years, 2 doses at the interval of 6 months, and from 15 to 25 years, we need 3 doses, 0, 2, and 6 months. So this dose schedule, I'm not aware, and though I think
that's why I brought it to you.
Yeah,
WHO has presented this. Even
okay, so
in India, there are 7 states who are to be included in the vaccination schedule.
Yes.
And some are having 2 doses and some are having 1 dose. Okay, so we will have our own data, but this is what has been presented by WHO. Whether it is a quadrivalent vaccine or it is a nanovalent vaccine, that doesn't matter. The dosage of both remains the same. Now, these are situations that we are going to discuss. That supposing a woman is 18 years old. She took 1 dose and then she went to the hostel to study and didn't take the 2nd dose. Now, after 1 year, she comes back. She has missed a dose. So what now? Does she take 2 doses or does she take only 1 dose?
I think 1 dose will be enough.
One dose.
Good. That is because in vaccination, no dose is 0 dose. Now she has got pregnant. 1 dose has been received. She has to get 2 more, but she got pregnant. Now what?
It
Does
should
she
not be
have to have
given
an
because it is
MTP?
a live vaccine, so it should not be given in pregnancy, though it
It should
doesn't
not-
got much effect on the fetus, but still, I
Ma'am,
think studies.
Ma'am, may I correct you, please? It is not a live vaccine.
It's a recombinant vaccine.
It is a
Virus like
recombinant vaccine which has no viral DNA. It
Virus
is
like
only the shell, the L1 capsomere that is included in the vaccine. It is not a live vaccine.
L1 envelope that resembles virus antigen. So that resembles
Agreed,
virus
but
antigen.
it has no DNA. It has no DNA, and therefore you do not do an MTP. Now she got pregnant. So when are we going to give her remaining doses?
After she delivers, ma'am. Because
I
the
think,
safety
yeah.
is not
I
treated.
agree.
Safety
After she
with the
delivers.
pregnancy is not treated.
After she
Yes.
delivers, but she can continue with the pregnancy.
Yes,
Yeah.
it is not harmful
Yes.
at all.
Yeah.
At all. Now, can some other vaccination be given along with the HPV vaccine?
Yes.
Like influenza
Yes.
or
Yes.
hepatitis B?
Yes.
Yes.
Not contraindicated.
We can give.
So, yes, that is correct. Can we vaccinate when she's lactating?
Yes. We
Yes.
can.
Yes, but
This is
it
the
has
best
to be the quadrivalent vaccine by MSD.
Yes.
Boys to be vaccinated?
Yes.
Yes, boys can be vaccinated.
It will protect from anal cancer, penis cancer.
Now,
What?
this patient has been treated for squamous intraepithelial neoplasia. She had a lesion, a colposcopy was done, the lesion was treated. Do you give the vaccine or don't you?
Yes.
Can be
We will
given.
give.
Can be given.
Severity
now
will be decreased.
Yeah,
Severity will be decreased, so we will give the vaccine.
It may protect against the invasion and proliferation by other kind of human papillomavirus, which she has not been exposed earlier.
Yes, yes. So now, do you need to do any testing before giving vaccination?
No.
No.
No, but we have to take the history whether she is any allergic to yeast material or other things.
She just
Only,
needed
but no testing. Any
routine
testing not
care
required.
and
Now
HPV.
she is immunocompromised. She is a known case of HIV, or she has had a renal transplant.
She
Would
can
you like
take.
to give the vaccine?
Yes.
Yes.
She can take the vaccine.
Sure.
Such patients are priority patients.
They should get the vaccine.
Yes. So now we will discuss what are the barriers to vaccination. Now, what do you think are the barriers at the level of the healthcare provider? We are all healthcare providers. What do you think are the barriers?
I'll say it is like limitation of our time. We do not have enough time in our busy clinic to counsel them and give the importance of getting investigated, get checked, and vaccinated. If we have enough time, or if we have an assistant, we have a health provider, assistant, a nurse who can counsel them and make them understood the importance of getting tested, getting vaccinated, I think the acceptability will be very high.
Do you think putting up a few flex or banner type of thing or a standee would help?
Yes.
They must,
Definitely will help, but will need more public awareness because
yes,
most
they
of our
must
patients,
stimulate
they are
their
not aware that the existence of such a vaccine.
See, what I'm saying is we are talking, these are all the points that we are going to discuss. What about the healthcare provider? At the level, at our level, we don't give time. That is what we have discussed. The second question I'm asking you, do you think, what about the healthcare beneficiary? Doesn't have knowledge. What do you think about the society? Does the society have any barriers for the vaccine?
Cost is one factor.
Let it be rapid
availability
fire.
is
Come
another.
on.
Cost is one factor, availability is another, and they are not sure whether it will be really helpful. Only patients who has seen a patient suffering from cervical cancer or a precancerous lesion, they are willing to get the vaccination for their children or for their relatives. Most of the patients, they think they will never get disease, they don't want it, and those who are aware, they don't know where to get it, and those who want to get it, it's costly for them. So those are the factors.
Most important is
do you
lack of
think we are
awareness.
over-informing them? Do you think we are over-informing them?
No, ma'am.
I'll tell you, when you have to give your patient tetanus vaccine, Do you explain everything about tetanus?
No, ma'am. They are
Not
already
much, not much.
They are already,
No,
have,
even
They
if
are
they
always
don't
trying.
know, but you don't give them a lot of information. When you're giving them influenza vaccine, what do you tell them about it? Nothing.
Nothing much.
Right? You write on your prescription and your nurse will give that vaccine.
Yes.
So I think the barrier is in our heads. We are not writing it on a paper. If you write it on the paper, the patient will go and ask outside. What is this written? Should I get it? Should I not get it? What is the cost? Why are we taking decisions on behalf of patients that the patient can't afford, the patient will refuse? I think, all these barriers from the healthcare providers should go away.
Yes, ma'am.
Many
That's
of
very
you
right.
are cancer doctors. Many of you I've seen in your intros are also practicing IVF and all. You never consider the cost there, do you?
No.
That we will not tell the patient IVF, she will not be able to afford it. You're not thinking that. Whereas it is 1.5 lakhs. Here it's 2,000 rupees or 4,000 rupees. So we need to actually remove our barriers. That is what I think. What are your suggestions about increasing up vaccination?
First, bundling of vaccination when they come at a certain age, do they get Tdap vaccination or meningitis vaccination? The pediatricians or any gynecologists who come to certain age group, they should try to give HPV vaccination just like any other vaccination. And another thing is, we need to explain to them why they need this vaccine. And another thing is, if they have any queries, they should be answered promptly, clear, make them their doubts clear so that they are willing to go ahead with the vaccination. And anybody in the hospital setting, like from the front desk to the nurse, everybody should be well aware that there's such a vaccine. If some patient comes and asks and inquire regarding this vaccine, everybody should be saying, yes, you should get it. It is available here. This is the dosing. So that's how we can increase the vaccination.
Now, do you think it is a vaccine that should be linked to sex or infidelity? That, if the wife turns out positive, HPV positive, you've done an examination and she's positive. Do you think that infidelity should come into it? Or sex should come into it?
No, ma'am.
So I think everybody is clear that we should de-link it from sex, right?
Yes.
Yes.
Usually, we all know that.
Yeah. There's an assumption. Yes.
That it spreads by sex. But again, we are not going to actually say that to the people.
Yes, ma'am.
So what do you think about political will? Now the government is already going to give it in 7 states free of cost. So the political will has started. Do you think we have the infrastructure?
I think, ma'am, we have
vaccinate?
because government is already vaccinating children below 5 years of age against many of things, DPT, measles.
The government vaccinated the whole country against COVID.
Yes. Yes. Government has.
So we have the infrastructure.
Yes.
We have the infrastructure. We have the digital platform. We have everything. Now the thing is to go ahead and actually do it. And all of you are right. It's when the government does it, it will really get done. Now, my question to all of the panelists, do you vaccinate? And how do you choose your candidates? To whom would you offer the vaccine?
Madam, it is best to go to the schools and tell the teachers first. We have to educate the teachers first. And when the teachers tell to children, let us say of class 8 or 9, the children will accept the teacher's wording. So if we go to the parents, and there is no need to tell them.
No, sir, you are in your clinic. How do you choose which patient to tell that you should have the vaccine or not?
It is a universal vaccine, universal coverage of all the children from 9 to 14, as you said. That's a primary vaccination. And it should start from the schooling of class 8 or 9. Then this is what the England, UK has done and our Western world have done. So if at all we are going to achieve the universal coverage, we have to go to schools and tell the teachers and then vaccinate these children in the school itself. And there is no need to tell about the sex. It is transmitted by the sex. Is what you call the HPV virus. Tell them. If the parents ask, tell them, oh, it will prevent the cancer. It's the cancer of the womb. It will prevent in the future, and they will accept it. They are not going to accept ask the etiology of cancer cervix to us. So we have to educate the teachers and start this universal coverage from the schools onwards, the way the UK, England, and other people have done in the Western world. Then we can
Thank you, sir.
achieve.
Thank you, sir. Now, this is the WHO statement that through cost-effective evidence-based interventions, including HPV vaccination of girls, screening and treatment of precancerous lesions, and improving access to diagnosis and treatment of invasive cancers, we can eliminate cervical cancer as a public health problem. So we are 40,000 gynecologists, and this is still the state. So now we've spoken about vaccination. Does anyone want to add anything to the vaccination strategy? Any of my panelists, anybody wants to add something?
We have to be sensitive enough to give a proper counseling in a way that it does not make her anxious or very fearful. And we should try to give and cover as much as people who come in contact with us. Even in busy chamber, we should try not to miss out any single lady. Even one life saved is worth counseling.
Ma'am, may I answer
Yes,
the
ma'am. Go
previous
ahead.
question?
Yes.
How I give vaccination in my clinics. If any unmarried, usually the age of marriage is not quite late here also. So any unmarried women comes, I advise them to get a vaccination. Any adolescent girls comes, I advise them for vaccination. And I also tell their mother if they have any siblings, girls other than the adolescent girl who's coming for some menstrual problem or something, I ask them to get vaccinated. And then any patient who comes with an HPV, which is negative, any age group, I offer them that there's something called HPV vaccination, which you can go ahead because your HPV is still negative. Then another thing is even HPV positive, if they are receptive, I still advise them for this thing, vaccination. And any patient who has a family suffering from some precancerous or cancerous lesions, they are very receptive to this vaccination. So I had a family who wanted their entire family and siblings and cousins to be vaccinated. So those are another group of patients which are very receptive to any advice regarding vaccination. And today only I got a patient who was like, there's certain vaccine for womb cancer, she was saying. I corrected her, it is not womb cancer, it's cervical cancer. So I think this public awareness campaigns which are happening now and then, it has increased a bit. So at least some information are getting to the public level. So they are coming to us just like that for vaccination.
That is true. And the good thing about the new serum vaccine is that the cost is 4,000 rupees and there are 2 vaccines in that. So you would need to have 2 people and 1 dose would cost 2,000 rupees to the patient. That is the current rate and it is already in the market.
Madam, why not wait until the July when our Indian vaccine comes out? Indigenous vaccine.
The serum vaccine is the Indian vaccine. The serum vaccine is the Indian vaccine. It has already come into the market.
That is
it is being sold to the government at a separate rate, but it is in the open market at 2,000 rupees per dose. It's an Indian vaccine.
That is called Sarvavac.
Yeah, that's
Sarvavac,
right.
Made by the same company that made COVID Shield.
But I think it is going to be given free to the children. I think government is going to
government rate is what they have also decided. That is all around 300 to 400 rupees per dose.
Yeah.
But now, what is the market? Dr.
Sir,
Jain has
the government would be giving it specially to schoolgirls between 9 to 14. But the licenses from 9 to 25 years, you can give it to everyone else. The government will not give it free to everyone else. The catch-up vaccination, the girls beyond 14 years, 15-year-old girl, will you not give her the vaccine? So you need to know the cost as well. So now we come to the next. What is screening? How do you define screening?
Should I answer?
Yeah. It's only four of you here.
Okay.
And I'm going to involve Pranay sir as the expert now.
Screenings are the modality of testing the cervix by which we can see whether is there any evidence of cellular changes. It can be like a liquid-based smear. It could be HPV.
No, we will not go to that. Ma'am, I'm asking you, what is the definition of screening?
Screening.
What is screening? Oh, the epidemiological definition. Oh, these are the modalities of tests where we select the populations. It's not a diagnostic modality. It just make them into probability of having the disease or not having the disease. These are just,
so screening is basically done on healthy individuals.
Yes.
It is not done on a diseased individual. It's a rough sorting process. Separates the people who probably do have the condition from those who have not. It's not 100% accurate. It does not provide certainty, but only a probability where a second test for diagnosis is required. So the purpose of screening is to identify people in an apparently healthy population who are at higher risk of a health problem or a condition, so that you can offer a treatment and the outcome can be better. Now, Jitendra sir.
Yes, madam.
What is the aim of cervical cancer screening?
Essentially to prevent cervical cancer or detection.
Yes.
Very early detection of the pre-invasive cancers. That is the whole idea of doing screening. Early detection
Sir,
of the
actually, screening is not for cancer.
Pre-invasive, I said. Pre-invasive
Yes,
means,
so then it's not pre-cancer. We have the principles of screening.
Yes.
These
find the high-risk population which can have.
These fit for cervical cancer, and the condition is an important health problem. There is accepted treatment for recognized disease, diagnosis, treatment available. Latent or early symptomatic phases there. There is a test for examination. It is acceptable. Natural history of the disease is known. There is a policy to treat patients. Case finding is less expensive than the cost of the disease, and it should be a continuous process. So here is the difference. Early diagnosis of cancer and screening. This is the difference. You may screen a lot of people and find a likelihood in 2 people, whereas when it is early diagnosis, it is only the symptomatic who are going to come to you. This is the flow chart. This is the flow chart. And Dr. Mukta, would you like to explain it?
Yeah, for any screening test, it is applied to the healthy population and it identifies the more which have the likelihood of having the disease. As you said, a screening test is like a sieve, which will filter the unhealthy from the healthy. So for any screening test, we should invite the population. We should have our fixed screening criteria to which the screening test is applied. And what is the age group to whom we are going to screen? What will be the modalities? Will it be free? Will it be government sponsored? Or how will we screen? Where will be the centers? And how will we dispatch the report? Then our test should be agreed upon that these are the standard test for screening.
See, now WHO has done most of it for us. We know which test to do. We know how to diagnose the screen positives. The important point that I wanted you to bring out is that screen positives have to be treated.
Yes.
A screening is not complete until the screen positives are treated.
Agreed.
That's it. You cannot just look at it and leave it. So there are various tests available that we are going to talk about. So what is the difference between sensitivity and specificity?
Sensitivity is the ability of the test to pick up as many diseases as possible, and specificity is the ability to tell that certain tests, if that to identify false negative.
In simpler terms, a screening test should be more sensitive, so that it may be false positive for few, but all the true positives will at least be selected.
Agreed. So this is the very important criteria, that your screening test should have more sensitivity. Specificity can come by triage, but at least you should not miss out anyone who is positive. So this is how it is. If you increase the sensitivity, specificity will go down. If you increase the specificity, sensitivity will go down. These are the terms that we use all the time. Right?
Yes.
So, Dr. Mukta, would you like to read them out?
Yeah, sure, ma'am. Like we discussed that among the positive who have the test positive, few will be true positive and few will be false positive, and same with the negative. So the sensitivity is like the total number of true positive among the total number of true positive, like that who are positive in the test and false negative. That means they are having the disease, but somehow their reports are being given as a negative. So sensitivity is to catch up actually the diseased one, and specificity is about those who really don't have the disease, like to catching up true negatives out of total who are true negative, or those who are really negative, but their reports somehow is given as positive. So positive predictive value is like true positive among all the positive, and likewise negative predictive value is true negative among all those reported negative in the test.
So this has some false negatives and this has some false positives. What happens if a patient is screened? The screen may be normal and you have these two things: false negative, true negative, false positive, true positive. And then what happens if somebody is true positive? What are the 4 things that can happen?
If we pick up true positive early, then obviously we will treat the disease at the earliest, and obviously outcome is better, because this is the beauty of a screening test, that the time period between the onset and the symptoms, the asymptomatic period, is pretty long. So we can pick up the disease early and we can have a better outcome because of early detection and treatment of the case.
Do you think there are what are the benefits and harms? Dr. Sindhu, what are the benefits of a screening project?
Yes, ma'am. Screening saves lots of life and it is very cost effective. Like even if we save life, a patient is protected from having a cancer cervix in advanced stage, the cost is saved. That is the biggest benefit. It is very easy, cheap, accessible, unacceptable. That is the good part of it. Loss is only one thing. If we pick up any false positive, patient is put under unnecessary triage, unnecessary further investigation, and psychological trauma also.
One thing I would like to ask Dr. Susie, what would you prefer, missing a cancer or over-treating a patient who doesn't have cancer?
Overdiagnosis is always better than missing a cancer.
Yes.
Hence, we choose a screening test with a high sensitivity.
I agree with
Dr.
Dr.
That is why I think this is more towards green than red. Am I right?
Yes, ma'am.
So these are the targets. Again, we remember them. And these are the advice given by WHO that you need to understand barriers to access service and create an environment, integrate screening and treatment services in the primary care package, promote a screen and treat approach, ensure an affordable supply of quality assured high performance screening tests and treatment devices, and strengthen lab capacity and quality assurance programs. Now, all of you are gynecologists. Before I go to the next slide, I want to ask you, what do you think? I want everyone to give a very quick answer. Do you think BIA is better than HPV? Pranay sir?
No, I think HPV is better.
HPV is better.
HPV is better. Dr. Mukta?
Madam, all this time we are doing
It depends upon the resourcefulness of your. So if we talk about more resource and the village setup, then BIA is saving a lot of lives. If we talk about sensitivity, HPV is obviously very sensitive than BIA. So
See, actually, Dr. Mukta, there are n number of papers that tell you that VIA in the long run does not save any lives. What you are doing is basically downstaging cancer. You are not detecting pre-cancer, which is entirely different. That is not the purpose of a screening program. The purpose of a screening program is to detect a pre-cancerous lesion, not a cancer at all. Okay, so we should forget resources because you need to calculate all resources. I tell you, you talk about a VIA. Now that VIA training, then the VIA that is done, what is the quality assurance? You see the point number 5? Point number 4, you need quality assurance. Who's going to assure the quality? You, all of you. How many of you are doing colposcopy?
We all are, most of us are doing. But VIA, I do not know. VIA people are doing or not because we are in a city.
No, I'm asking you, you do a colposcopy, which is so much magnified. There is such a good light. And still, the diagnosis is not staring you in the face. You have to wait. You have to look at it. And VIA, without anything, without any magnification, with a torchlight, do you think it's going to be as effective? It cannot be. And we as Indians today, I would say, need to come out of that mindset that we are a poor country. We are a low resource country. We are not. We are not. Every woman is wearing
It's very true.
lakhs of rupees of gold on her body. And that body will be destroyed by cancer if she doesn't get screened and treated. So it's where we place our priorities. We as doctors, I would request all of you, get out of that mindset that we are a poor country. This cannot be afforded. That cannot be afforded. Because whatever is your priority, you do it. I know in Orissa, even the maids that work in our place, when they have a wedding in the family, every relative gives, 10 grams of gold to that person. However they get it. Every relative is giving 10 grams of gold to the person who's getting married. Today, the cost is 60,000 rupees. How much is the cost of an HPV test?
It's around 2,000 rupees.
So what are we thinking of? What are we thinking of? We are not offering it. We are not offering it. We are always taking the excuse that the patient is poor. Please come out of that mindset. Every human life is equally important. The same dignity is required. We should try to offer what we would like for ourselves to our patients.
Madam, are you telling about HPV alone or co-testing? HPV and
co-testing, co-testing, sir, co-testing.
Yeah, that's what I think.
This is where we are now. And now we come to the screening methods. So these are the 4 methods. Who was speaking right now? Padi sir was speaking?
I was speaking. Jitendra Panda.
Yes, sir.
I was speaking.
So would you please like to go ahead and speak on the basic 4 methods?
Madam, we have already enumerated cytological HPV testing, visual inspection, and then physical methods. What do you
So
mean by
what are
physical?
the cytological methods? What are the cytological methods?
This is simple pap smear or liquid bed cytology.
What
LBC.
would you prefer? What would you prefer?
Nowadays, I prefer LBC always, but it is slightly more expensive than again boils down to money. You don't like that. But pap smear is usually cost 200 to 300 rupees, and LBC costs nearly double the amount of that. So I look at the patient's status,
Sir,
economic status.
May I ask you, what is the advantage of an LBC over a simple cytology?
The LBC has got more sensitivity. It's very true. LBC sensitivity is much higher than your pap smear, and false negative is much less in the LBC.
So sir, for 300 rupees, don't you think that woman deserves more?
No, I always go for, madam, I go for LBC. LBC, I take a, I'm withdrawing my comment. I'm not talking about money anymore. I am saying LBC is better than pap smear.
And moreover, sir, if it is high grade lesion, then papilloma virus can be tested concomitantly with that same sample.
Okay. So this automated scan and autocyte, autopap, I don't think it's available with us. What we have is the LBC and the conventional PAP. And as a team, we have decided that LBC is better. Okay.
Oh, yeah.
Do you have any problem with getting the reagents for the LBC? Because every patient has to have a separate bottle. Is the availability good wherever you are?
Yes, ma'am.
No.
Yeah.
Okay.
No. In my place, we don't have. So I have to ask them, like, if you want to go ahead with liquid-based cytology, which is better, she should get the bottle from the place where there is. They are not usually kept in our OPD. The place where I used to work before, we used to have lots of LVC and cytobreasts. So as soon as we do a Cusco speculum, any examination, we take it straight away. But right now where I am, I don't have. So I ask the patient to get the bottle, and then when they come and
but you would still get it, right?
Yeah.
It's available. It's not that you're not getting the bottles at all. So these are the limitations. These are the limitations of pap smears. Dr. Sindhu Bala?
Yes, ma'am.
Go ahead.
Limitations, ma'am. We all know that it is a very highly specific. If we are getting a abnormal cell, that means it is there. It does not come from sky. But the fallacy is it does not pick up all the suspected cells. It has a tendency to miss out. So I prefer it to be done by a doctor gynecologist in her own chamber with own hands, is while visualizing the squamo-columnar junction and the transformation zone. And it has to be read by a pathologist who has like quite confidence in reading it out. And I usually combine with papilloma virus screening as well.
Agree. So the thing is that it needs a repetition. It needs a cytologist.
Yes.
Doesn't help in postmenopausal women most of the time, where the squamo-columnar junction cannot be seen.
Inside. Yes.
And a smear will never tell you where the lesion is. It will tell you there is something wrong, but it will not tell you where.
Where? Unless until it is an obvious lesion, then that goes into a different category.
No, but you would still have to go ahead and look at it.
Yes.
You would have to do a colposcopy. Right?
Yes.
So now we continue to the HPV-based test. We have HPV DNA, we have HPV RNA, we have newer markers, then we have these stains, and then the mRNA protein testing. Which test would you like to do? What should be the basic criteria?
Ma'am, I have
DNA. We are doing HPV
DNA. And
HPV
DNA.
Which DNA? Are you doing a hybrid capture or a PCR?
Mostly they do PCR, ma'am, I think. Because we hardly get more positive. I have only come across 1 or 2 patients. It's not so prevalent in our country because
you need to go to the WHO website. I've put in links here. There are only a very few valid tests. In India, there are only 2 valid tests for HPV DNA screening. One is the hybrid capture test and the other is the COBAS test. No other test is valid for HPV testing. A PCR is not diagnostic of precancerous lesions. All the data that WHO is showing you is on hybrid capture 2. Millions and millions of cases, it's all hybrid capture 2. So this you need to know. So what is important here is that HPV DNA means you have to do the hybrid capture or the COBAS test. RNA is E6 and E7. It is more specific, like a pap smear, but it is less sensitive, which is always what you have to understand. It's going to miss out a lot of things. P16 is for HPV pathology and Chi67 is for endometrial cancer. So P16 has to be done on a histopathology specimen. You need a block of tissue which can be stained. So these are the basic things that we need to know about. These are the tests. This is from the WHO website, out of which only CARE HPV is available in government setups. We have hybrid capture and we have COBAS. Nothing else is available in India. Then you have the biomarkers, the E6, E7 mRNA. This test is available in India, but again, it is not a screening test. It will differentiate. Supposing you have done a biopsy and that biopsy is giving you CIN2, indeterminate. As we understand cervical pathology today, there is no such thing as CIN2. There is HPV infection and then there is HPV related disease. So HPV infection is what we understand as CIN1, low-grade squamous intraepithelial neoplasia. And then the high grade is once the precancerous changes have started, the DNA damage has occurred. That can be seen by a P16 stain in a biopsy or by E6, E7 in a smear. This is all I want you all to remember. So, for us who keep excusing ourselves, this is the latest guideline by WHO. Dr. Susie and Jitendra sir, would you read one by one? What do you suggest for the general population?
WHO suggests either of the following strategies: HPV DNA detection for the general population. I'm talking about general population. HPV DNA detection in a screen and treat approach starting at the age of 30 years with regular screening every 5 to 10 years. And HPV DNA detection in a screen, triage and treat approach starting at the age of 30 years with regular screening every 5 to 10 years.
Jitendra sir?
Yes, madam.
What about women living with HIV?
The HPV DNA detection in a screen, triage and treat approach starting at the age of 25 with regular screening every 3 to 5 years. Is that a WHO suggestion? Now I thought, no, WHO suggested, I have nothing to say. So I thought that should be done in 25 years as well, starting from 25. But anyway, it's a WHO suggestion. So it says that after the only HIV patient, it has to be screen, triage, and treat to be started after from state of the age of 25. Anyway, that's okay.
So now what they have said is that if any woman is HPV positive, you need to do her HIV test. I don't think we are doing it, but that is the suggestion from WHO, that anyone who has a cervical lesion should also have an HIV test. So we have the visual methods now. You have Mukta is still there. Dr. Mukta,
Yes,
would you
ma'am.
like to say something?
Yeah, for visual methods, we have a per speculum examination, then a visual inspection with acetic acid, visual inspection with acetic acid under magnification, and visual inspection with Lugol's iodine. These are the visual methods without any magnification or colposcopy.
So, have you done it ever?
Apart from per speculum examination,
Have you applied acetic acid ever to your patient when you're doing a simple PS?
No, not with the PS, with colposcopy only.
Yeah. Okay. The colposcopy is again not a screening test, right? It is a treatment test.
Right. That's a part of triage, yes.
So, VIA can be used as a triage test. A patient is HPV positive, then you can proceed and do a triage with VIA. These are the other methods which are again for triage. Physical methods are all under trial. Now, what is the principle of visual method? What does acetic acid do?
Coagulates the protein in cells and makes it white and opaque.
Okay. So what is the difference between a precancerous cell and a normal cell? Squamous epithelial cell, which is normal and which has precancer. What is the difference?
NC ratio is high, ma'am, in precancerous cells. So they have high amount of protein. So they will coagulate and they will look more white.
Agree.
Compared to the rest of the cell.
So this is the visual method, which is low cost and it can be done immediately. Can be done by paramedics. I really don't understand how that can happen, but that's it. So
in places where we do not have colposcopy as a backup, this is a good, supplementary method.
Agree.
To do.
Agree. I said it is a triage. It's not a primary screening, is according to me. But WHO says that you can do it. Indian government has said that you can do VIA for primary screening. The results of VIA are, Dr. Sindhu?
Results of VIA, it could be like negative, all area are okay. It could be suspicious, patchy flecks of some indistinct white area, or it could be positive, sharp, distinct, marginated white area around the os.
There is no inconclusive. Either it's negative or it's positive. What you consider inconclusive goes into positive.
Yes.
In VIA, it is either negative or it is positive.
Yes. Yes. And it gives an idea from where to take the punch biopsy. Even if we do not have a colposcopy available, we can take biopsy from that place and we can send it for a further report.
That is very correct. What are the limitations?
The same limitations. Anybody wants to speak? Because it's already
lots of false positive tests, and depends on a little bit on expertise of the person who is doing. They need to be trained, so the results could be misinterpreted.
So this is what we've already seen. So there are 15 questions for which I don't really think we have time. So I'm going to take you directly to rapid fire. Which vaccine would you, I want each member here to answer that. Which vaccine would you like to give to the young ones in your family?
Nonavalent.
Nonavalent,
Okay.
yes, ma'am.
Nonavalent, Jitendra sir?
I'm still not sure whether Sarvebak is available in our country. I don't think it is.
It is.
It is.
Oh, it is available.
Gardasil is available.
Yeah. No, I have been using Gardasil so far, but if Sarvebak is available, I will go for.
No, would you go for nanovalent or quadrivalent?
Well, certainly nanovalent is better. Nanovalent is better.
So then you would go for a nanovalent vaccine.
Sure.
If
sure,
Himali
sure.
ma'am is there, if she would like to pitch in and say something. would you, all of you, this is rapid fire. Would you recommend a cytology-based screening or HPV-based screening?
HPV, ma'am.
If I can combine both, I'll be happy. But if not, if only one, then HPV.
If you combine both, then it is HPV-based.
Yes.
Well, co-testing is much better than either.
What did you say, sir?
I say I go for co-testing, means HPV as
Co-testing,
well as
good. So that is
LBC.
called HPV. That is HPV. Which HPV test would you recommend?
HPV DNA with hybrid cancer.
Hybrid, yes.
So that is
Hybrid
what
of-
I wanted you to say. If you have to do a pap smear, even in a co-testing, conventional or LBC?
LBC. LBC. LBC, ma'am.
So another thing, there is a screen positive lesion. So would you like to go for screen and treat or screen, triage and treat? It's an
I would go
HPV
for
test.
screen and treat.
No, ma'am, I'll go for screen, trials and treat. I do not want to miss out a single case.
No, no. See, screen and treat, you're not missing anyone. You're over treating.
Yeah.
So, Pranay sir?
Yeah, I agree with the
Yes,
screen, try and treat.
Screen and treat.
I'll screen and treat.
All
Well,
right.
depends on the patient's compliance. If I see the patient is a good socioeconomic status and able to come back and is not going to disappear from me, I will certainly wait for skin, try and treat. Otherwise, I have to go for skin and treat under compulsion.
Okay. So, the last thing that I would like to say is that screen, triage and treat
Is
helps
better.
in the treatment of 50% less patients. Okay?
Yes.
But if your patient is non-compliant, just go ahead with screen and treat. So there is no one right answer for this. And organizers are here.
Yes, ma'am.
Monica, you want me to finish?
Ma'am, we have another 5 minutes to go. We can continue for the next 5 minutes.
Thank you for that. Then I would really like to go with these questions. Ekdam fatafat.
Madam, can I ask a question here?
Yes, sir.
Do you really think, as you have already said, you have already expressed your opinion, DIA is an ideal or it should be done?
No, sir. I am 100% for HPV, and that is what WHO says, that everything has to be shifted to HPV. Now, this is a quick answer, one person for one question. HPV is positive, acetic acid is placed on the cervix, and no lesion is seen. Okay, but the transformation zone is type 3. What are you going to do?
Screen and treat, ma'am. Treat. If
What
it,
will you treat?
since the transformation zone is incompletely visualized, so it's better to just treat straight away since she is HPV positive.
What will you do? What will be
ablative therapy, cryotherapy.
That's where you're wrong, my dear. If it is a type 3 transformation zone, you need an excisional procedure because you don't know how deep you have to go for the transformation.
Endocervical canal status, we do not know. We have to see
Yes.
it.
So that is why you have to take, it is a type 3 transformation zone. It has to be excision of the transformation zone. Okay?
Yeah.
What are the criteria for ablative treatment?
It should be type 1.
It should be type 1. Yes,
It
it
should not
should be
be
type 1. It should not be a repeat ablation. It should be the first episode. And there should be no suspicion of cancer. It should not cover more than 3/4 of the cervix. Okay, these are the criteria. If these are not fulfilled, you're not doing ablation. Now, the patient is not eligible for ablation and colposcopy is not available. What will you do?
As I said, ma'am, we can apply the acetic acid or lugolcidine and we can find the suspicious area in the OT and take a biopsy from that suspicious area.
Okay. Now, this is another case. VIA is performed as the primary screening. No lesion is seen. But TZS is type 3. What will you do?
Such patient needs colposcopic examination in the OT.
No, but again, it's
Or
type
at
3.
least
You see nothing. You have given the answer previously. Take an endocervical curettage or do HPV for a triage.
Yes.
What are the recommendations for skin triage and treat?
After screen positive, if anything is suspicious like HPV positive or low grade, we have to follow up not in low grade, in suspicious grade, higher grade. It has to be followed up by second backup test. It would be colposcopy. In my place, in my opinion, we go for a colposcopy examination and then colposcopy.
If she is HIV positive, would your treatment differ?
It has to be more aggressive, more frequent, and more suspicious.
No, the treatment doesn't change. Jitendra sir?
It doesn't.
Sorry, madam, I'm not with you. I didn't understand what you asked.
Means if the woman is HIV positive, she has a type 3 transformation zone and her HPV is positive. What will you do? We said we would do an excision. If she is HIV positive, will your treatment change? Susie?
No, ma'am.
I think we will still
Only
do
thing
an
is, it is
excision.
more frequent follow-up.
Yes.
No, the answer is it's the same treatment. So HIV positive, it's the same. We have a VIA-based screening system. Should we stop that or use VIA for triaging after HPV? Triage after
HPV after triaging HPV is good, better.
I didn't get what you said. You do HPV first or you do VIA first?
HPV first, then VIA is a better method.
Yes. Dr. Sindhu?
Ma'am, VIA I usually do not do without colposcopy. But yes, if colposcopy is not there, then I can go for VIA.
No, but first you would do an HPV, right?
Yes, that is the screening. It's the OPD.
Yeah.
No VIA, go for pap smear. All LBC.
Now, in the modeling, the price of HPV test considered, which is HC2, was $8.15. When you took everything together, it was $15.09. That included sample collection, lab supply, overhead, everything. How much is $15?
Around 1,400 rupees, 1,200 rupees.
Exactly. So it is not something that cannot be afforded because half the treatments will become less. You will not miss even a single cancer. As you can see with HC2, the false negative is 0. You will catch every single case. There is no false negative. Okay? So, when should we triage after positive HPV test for treatment? If you can do the triage. Okay? Is it ethical to treat all women with HPV positive result if there is no lesion on the cervix? Susie, this is for you.
Followed up. They can just be younger patients. They can be just followed up. They are cleared automatically in 3 years. So they are advised to come for follow-up at least yearly, repeat.
Listen, we are talking of women who are above 30. Our screening is starting at 30 years of age. Okay. So if you have screened, she is positive and you see no lesion, will you treat her? How will you define the treatment area?
Yes, ma'am. If there is no lesion, what can we treat?
Dr. Susie?
If the patient is HPV positive more than 30 years, and though the basic pathology is the ability to clear the HPV infection, so I think it is not wrong if we offer some ablative treatment to the patient straight away.
So how will you define how much area to treat? By the presence of gland openings and merothelium follicles, because they mark the border of the transformation zone. And that is the area that you're going to treat. Simple.
It should cover the entire transformation zone.
Yes. So use a standardized test, HPV-HC2 or COBAS. If she's HPV positive, should you tell her partner?
I think it should be left to the patient. They should, if they want to, they should be able to tell to the partner, but it should not be stigmatized.
Are you going to do HIV on a HPV positive woman?
Yes, ma'am. Just as now you have suggested, it should be done.
Because STI.
Now, if she has some other STI, should we go ahead with a thermal ablation?
I think it's okay, ma'am.
Not contraindicated, but it should not be repeat thermal ablation, just one time.
Yeah. Yes.
And the treatment for STI has to be given.
Yes.
Yes.
Healthy sexual practices should be emphasized upon.
Now, this is one dirty part of ours, that only 25% countries of low income group have given vaccine to their girls, at least one dose. So I thank you all for being with me. Thanks a lot for being very interactive and looking happy about it. Help keep the smile on this young girl's face intact. Vaccinate and screen. Thank you.
Thank you, madam. I thank you, madam.
Thank you so much, ma'am.
For a very enlightening talk. It was wonderful.
We are extremely
thank you, sir.
That we had such an interactive panel. Ma'am, thank you so much for taking efforts in highlighting the cervical cancer prevention and vaccination and how important it is. I take an opportunity to thank Dr. Priyanka Roy for the opportunity he has given for coordinating this event. I would like to thank our chief guest and guest of honor, Pai sir, TC Mahapatra sir, and Shamal sir for joining in. Our speakers, Manisha ma'am and Bhagyalakshmi ma'am, for their excellent inputs. Our moderators, Asha Jain ma'am, Rekha ma'am, and Ashok Padi sir, and the expert Himali ma'am, for their valuable comments and suggestions and very good take-home messages. Last but not the least, I would like to thank all the panelists who have been so interactive and given good feedback messages to all our delegates. And a big thank you to all the online delegates as well as Corona Remedies for being our academic partners. Thank you so much. We will meet on the 11th of May with the next session of the Public Awareness Committee with the North Zone. Thank you, Shatabdi. Thank you, Asha.
Thank you. Thank you. It was really great. You are an excellent panel. Thank you.
Thank you, madam. Good night.
So much.
Good night. Thank you.
It was very informative, ma'am.
Thank you.